gastro section. No, so attention span in our modern society is downward spiral. No, so chances are you might not reach the end of long conferences without becoming distracted. So the advantage of this conference, it will only consume a very short period of time so that it will capture your attention more easily. So we cannot express how thrilled we are to have you. Several amazing doctors are here today to share their expertise about the role of nutrition, and hope that you will learn a lot so that can help you and also me in our practice, so that our patients will be able to recover fast from their disease with proper nutrition. It means so much to have you all here. Again, we're so looking forward in a day with you. Please enjoy the conference. Thank you.
Thank you very much, Dr. Daet. Okay, so to start our program, so I have the honor of introducing to you our first speaker. So he finished his residency training in internal medicine at the United Doctors Medical Center. He had his fellowship training in gastroenterology at East Avenue Medical Center. He's a fellow of the Philippine College of Physicians, a fellow of the Philippine Society of Gastroenterology and Digestive Endoscopy. Currently, he's an assistant professor of the FEU-NRMF Medical Center and an active consultant here at FEU-NRMF Medical Center. So, ladies and gentlemen, our first speaker is Dr. Joey Alex Santos.
Thank you, Pong. Can you hear me? Okay.
Yes, sir. Loud and clear.
Okay, thank you. Thank you very much. It's a great pleasure to have this single topic conference with you guys. And I was tasked to give a lecture on basics of nutrition. So let me share. Can you see? Sorry. Screen share. Let me share with you. Now, can you see the screen?
Yes, sir.
Sorry. Okay. So let me start by citing a verse in the Bible, which reads in Genesis 2:16, and the Lord God commanded the man, saying, "In every tree of the garden thou mayest freely eat." So this is the very first commandment that was commanded to Adam when he was created, knowing that we really need nutrition. So therefore, I was tasked to discuss important in nutrition, including the macro and the micronutrients, discuss what is nutritional support, and discuss briefly enteral and parenteral nutrition. So what is nutrition? Food nourishes our bodies. It's a given, and it influences our health. Meaning to say, if for the residents, the interns, and the students, nutrition could make or break your patient. So I gathered some information. I thought this, Pong, I thought this was a very easy, but it was very hard to go back to the basics. So hard. I tried to to simplify things. Maybe we can, hopefully I can finish in time. Excusez-moi for my rusty French. So I had the liberty to translate this into English. Tell me what you eat and I will tell you what you are. So really, as early as 1826, they found out that what we eat influences our health and well-being. So with macronutrients, these are the nutrients we need in large amount, namely fats, carbohydrates, proteins, and water. Arbitrarily, they were assigned numbers, 9 calories per gram of fats, and then 4 calories of gram for carbohydrates and proteins, respectively. Meaning to say, they tested this in the laboratory. Calorie is the energy required to raise 1 gram of water, 1 degree of temperature. So they found out in the laboratory that fats give 9 calories per gram and carbohydrates and proteins 4 calories each. So meaning to say, what you read in the label, by the way, calories and kilocalories are used interchangeably. Whatever you read in the label, that may guide you in the nutritional program or nutritional advice that you will give to your patients. So the chief source of energy is the carbohydrates. You have three, the simple, the glucose, sucrose, lactose, maltose, and fructose. These are the immediately utilized fuel for the body. And when you have complex, you have starches like your rice, the bread, and it needs a little bit of processing so that it will be converted into simple sugars. This goes for the students, this goes a little bit of an interplay between physiology, biochemistry, and sometimes you base your decisions on those. And you have fibers. Unfortunately, we don't have cellulase like the animals, so we cannot digest fibers. If you or your patient plans to lose some weight, you feel the fullness by taking in lots of fibers without getting fats, because cellulose cannot be converted into simple sugars like glucose, sucrose, lactose, at least for human beings. So in fats, I had this caricature downloaded. uh, Meet the fat brothers and sisters. The bad fats are the brothers. I don't know. Is it really the male is the bad person here? But nonetheless, the bad fats are the sats, brother sat and brother trans, while the better fats are the sisters poly and mon. So when you have sat, you have saturated, these are fats that are solid at room temperature. You find this in meat, while you have your trans fat, it undergoes or it underwent hydrogenation. You put some hydrogen in the fats so that it will be palatable, it will be better utilized, and it's called hydrogenation. In doing so, the trans fat, that is the product, are the culprit of some of the lifestyle diseases now. While when you take in the good fats, the mono and the polyunsaturated, these are the fats that are liquid at room temperature found in plants. We have the essential fatty acids. You will read in the label, or you sometimes we prescribe, we give omega-3 and omega-6. Omega-3 fatty acids are the alpha linoleic acids, while omega-6 are the linolenic acids. For the students, you will find this useful when you go into biochem. So essential fatty acids, although they are essential, the intake must not exceed 30% of the daily food intake, or the RDA, the daily allowance that is recommended. In the essential fatty acids, we get from there the important eicosanoids or endocannabinoids, and some of the useful fats that is being, for the example, the cannabinoids. We have now the medical marijuana. It is being carried, ang carrier non ay essential, or rather fatty acids. So fats, they are used in insulation, cushion, they carry fat-soluble vitamins, the A, D, E, and K, and it provides integrity in the cell membrane. Whereas proteins, you have your chiral carbon in the middle. You see, in your right, you have the carboxy group. And on top of your chiral carbon, you can see you have the R group. And below is the hydrogen group. What is important in proteins are the amino group on your left. It changes while certain amino acids that you gain from your diet that is being attached to the amino or the end group. This forms the enzymes and all the necessary materials for building and repair, body defenses, energy and heat production. For the students, we have 9 essential amino acids. This is with the mnemonics of private Met Hill. If the examinations will ask you for 10, well, the 10th is a somehow hybrid, the arginine, which is what they call conditionally essential. You have your phenylalanine, valine, tryptophan, methionine, threonine, histidine, isoleucine, leucine, and lysine. Those are the 9 essential amino acids. They attach, look at the amino group on the left side of your screen. They attach to that amino group, and what they produce are certain enzymes that will be needed in bodily activities. Of course, after carbohydrates, fats, and proteins, we cannot really, really overemphasize the importance of water because water is life. 60% of our human body is composed of water, and around 71% of the world is water. So this is the rationale why we are being asked or ordered or being instructed to take in lots of water because it will water is a universal solvent, as they say, so it provides the vehicle for any activities in our bodies. Whatever is the source, whether protein, when they are broken down, forms into amino acids, fats into fatty acids, carbohydrates into glucose, they produce in your extreme right energy. Whatever is the cause, whatever is the the source, the energy production is the main goal. So for the students, you will find this a little bit boring because you cannot see them, what is happening, but it does happen. When an amino acid enters the cell, or a fatty acids, or a glucose, simple sugars, it goes into your cytosol, combined with pyruvate, and then passes through NAD, becomes NADH, goes to the mitochondrion, which produces the cells. That is as simple as I can give it to you. But for the students, you have to be more specific when being asked in the examinations. But the bottom line is energy production. We go now to the micronutrients. After the macronutrients, which we need in the body, we go to micronutrients, which in the form of vitamins and minerals. So vitamins, we have water soluble and the fat soluble vitamins. It's very easy. Only you have 4 fat solubles, A, D, E, and K, while the water soluble vitamins are the C, the B complex, folic acid, and etc. We also need minerals and trace elements in the form of sodium, calcium, magnesium, potassium, iron, and so on. These minerals and trace elements is an add-on in the process of the cells. You will also encounter biologically important elements like the coenzyme Q, inositol, and biotin. For the students, I simplified this. When you have your micronutrients, you have the subcategory of a macro, the bigger micronutrients in the form of calcium, magnesium, sodium, potassium, phosphorus, chloride, and sulfur. In as opposed to the micronutrients. Micro, you mean a micronutrients that is a little of the micronutrients in the form of iron, zinc, cobalt, molybdenum, manganese, chromium, fluorine, etc. So for the students, that may be important in the upcoming examinations. After you are introduced to the nutrients, how are we going to utilize them? So we have to digest it. We have to break it into smaller parts. Like for example, you chew. You chew your food well. We are told when we were younger, because that not chewing your food well will result in indigestion. So mechanical breaking into smaller parts by chewing your food well. In consonance with that, we need also chemical breaking of the uh, food particles in the form of digestive juices like your gastric, your pancreatic juice, etc., which is triggered when you eat your food. The moment you smell food, uh, your brain will send signal to the digestive system that will prepare the stomach, prepare the pancreas, prepare all the digestive juices necessary. So once the food gets in the stomach, they will be digested to be ready for absorption. So you have, as I told you earlier, you have, this is an interplay in the physio biochem part. So blood and lymph capillaries are very important. The circulatory system is important. Once the food digested, it enters the small intestine and the large intestine. So amino acids, fatty acids, long or short change will be delivered via the lymph. That is, so long as your circulatory system is intact, so we don't have any problem at all. After being delivered, we now metabolize the energy. It builds your cells, it repairs, it provides your bodily function. If you don't move at all, you still need energy expenditure in the form of your BMR, the basal metabolic rate. So once food gets in, you digest it, and then it forms energy. With regard to your BMR, these are the calories or the energy you need to maintain vital function. Vital function, even if you don't move, there is no change in body weight or body mass. You need energy to fuel the activities of the stomach, the kidneys, the lungs, the heart, the brain, the liver, and all. So even if you don't move, you don't gain weight, you still need energy. So you need food. But if you take in, if your BMR is high, like for example, and for the pediatric group, you are young, you are growing, you are under stress. Like for example, today in the pandemic, most of our patients we see in the clinics are under stress. Their BMR increases. In the opposite end, if you have thyroid problems, endocrine problems, your BMR may be lower. So men and women utilizes energy differently. For the students, this might be of help to you. But for the residents and consultants, why bother? Meron naman tayong BMR calculator. So that is the beauty of the internet. Hayaan na natin ang mga estudyante natin ang mag-calculate manually. Tayo, we can input. Okay? If you take in a lot of food, your body mass index, so this is different from BMR. This is BMI now we're talking about. Body mass index, pag marami kang kinain, tataba ka if you don't have any activities. So body mass index, we have a chart. We have underweight, normal, overweight, obese, and extremely obese. So just take note of those. Kasi baka pakain sa ating mga pasyente and yet they don't need it anymore. So what if your patient can't swallow? Patient is debilitated, problems with appetite. Sa appetite stimulant, it can be discussed later on. When your patient is severely malnourished and cannot absorb nutrients to the digestive system, what are we to do now? As doctors, the goal is to give adequate nutrients to maintain bodily function. We already discussed that a little while ago. And nutritional support is indicated when your condition is compromised and in an extended period of time. So at all costs, we need to deliver the adequate nutrition. So we have this nutritional support. The ration to mitigate the effect of starvation and to favorably alter the natural history and response or to treatment of a disease. Meaning to say, we need to get the body going the soonest possible time so that the recovery would be faster. So other reasons, minimize starvation, specific nutrients correction, provisions of adequate calories. We already talked about that. Under stress, debilitated patients, increase your BMR, minimizing metabolic complications as much as possible. We manage and correct our fluid electrolyte imbalance, and we have to maintain adequate urine output to maintain normal homeostasis. And if at all the body will go into recovery, we also modulate the immune response of our patient. But how do we support now? This is the third objective now is to present to you enteral and parenteral nutrition. When you say parenteral nutrition, you utilize the veins of your patient. It can be central vein or it can be peripheral vein. Whereas enteral, you utilize the alimentary canal. The mouth, you feed the patient as much as possible. The earlier, the better. So this is a representation, a rough representation. On your left, you have your parenteral nutrition. You feed them intravenously, feeding through the central vein, and feeding through peripheral vein. Whereas your enteral nutrition can be delivered via the stomach through nasogastric tube, the nasoduodenal tube, or the nasojejunal tube. And you may also do gastrostomy. This is being done through PEG insertion or gastrostomy, care of gastro, or gastrostomy tube insertion, care of your surgery. And feeding tube that leads to the artificial external opening, the jejunostomy. So these are the form of enteral and parenteral nutrition. So how do we decide? The decision of selecting the mode of administration is based on timing. If the patient needs only a short period of time to deliver the necessary nutrients, well, you can opt to give through tube feeding. In contrast, if this is a long term, you have to have a percutaneous tube inserted in the form of gastrostomy, the duodenostomy, or the duodenostomy. But you have to remember there will be consequences. For every action, there will be reactions, tube-related complications, the absorption complications, and so on and so forth. So you have to take note of this. For the residents, please take note when you insert NGT, please take note of this possibilities. When you give food through the NGT, please take note of the osmolarity of your food. While in parenteral, we already discussed this. You can give it centrally and peripherally. There is such a thing as peripherally inserted central catheter. During those times, in the earlier times, I think IM residents can insert the peripherally inserted catheter. But now I don't know if it is being done. For me, I haven't experienced it inserting a peripherally inserted. We usually call surgery for that. And the types, so it depends on the osmolality of the solution. If the osmolality is more than 7 milliosmol per kilogram of water, you might as well place it centrally. Whereas if it is lesser than that, the concentration, you can place it peripherally. So the common indications for peripheral nutrition, parenteral nutrition, when you, after trying or after giving enteral, then it failed, and you have your severe acute pancreatitis, short bowel syndrome, mesenteric ischemia, bowel obstruction, fistula. These are the common indications. Also, as there are complications in enteral nutrition, there are also complications that will be taken into account when you give parenteral nutrition. Like, for example, you have your acute complications, you have your hypoglycemia, it can be hyperglycemia, metabolic acidosis, electrolyte imbalance, can be also catheter related. You have your thrombosis, necrosis, and so on and so forth. You have your chronic, and you have your infection to take care of. But after a long day, after all has been said and done, doctors should always take into consideration the condition of the patients, the type of nutrition that you're going to give, and you have to have a good background on biochemistry and physio when it comes to correction or giving. You also need nutritional consult with our nutritionist and a group of other doctors. For example, the patient will go into surgery, and you have to consult the surgeon so that the decision will be of benefit of the patient. And let me end my lecture with another verse from the Bible. But he answered and said, "It is written, man doesn't live by bread alone, but by every word that come out of the mouth of God." So with that, thank you very much for your kind attention. I hope we have delivered to you what we need, basics of nutrition. Thank you very much.
Thank you, Dr. Joey, for that very excellent lecture. So the floor is now open. If you have any questions for Dr. Joey Santos, maybe we can accommodate 1 or 2 questions.
There's
Okay,
a question
so
here.
there's a question, Doctor. Sir, are there any substitute nutritional support for patients who are to be maintained on NPO, but there are no available TPN? So if the computed kcal per day is not met. So for
Well,
example, the computed kcal for the patient is 1.6, but we only have 1,000 kcal TPN.
yeah. I do agree. That's a problem, Dr. Pong. That's a problem. Yung mga pre-filled or yung preparation nila ay sometimes it doesn't fit our patients. So this is just personal, ano? Kasi kanya-kanya tayong ano eh. Hindi ba sometimes we deliver the TPN, let's say sasabihin mo, run the TPN for 24 to 36 hours. Sometimes they give it 24 to 48 hours. So to answer Edmund's question, for me, ano, hindi ko alam pong if you have answer to this, but honestly, the computed kcal is 1.6, but we only have 1,000 kcal TPN. There is a 1,900, I think, preparation, 1,400. So yung closest siguro, that will be a much wiser decision. The closest that we can give. Pangit kasi yung 1.6 yung required sa'yo, you only give 1,000. Di ba? I mean, logically speaking, I'm just thinking aloud. But if you have 1,400 kilocalories as against 1,900, the required is 1.6, siguro kung central yan, pwede mo i-deliver yung 1.9. Kung peripheral yan, baka naman kailangan mo lang nung 1.4. Sa akin, I don't know with other gastro who is listening, hindi ko alam pong kung same din ang ano mo, ang point of view mo with that.
Yes, sir. Actually, the problem dito is more of ano eh. Kasi there are preparations naman. So the preparations are available. Ang problema is the availability.
Yeah.
So we have the 1.9, we have the 1.6, 1.5, 1,000. Meron ng 1.2, may 1,000. No?
Yes,
So,
tama.
ang problema is really the procurement process. It's how the hospital would procure these things, no? Pag kailangan po kasi. Kasi nandun naman siya eh. So, sometimes if really needed, can we ask them to buy outside? No? Kung yun po talaga yung kailangan na required number of kcal for this patient. Okay? So, medyo logistics din po yung issue.
Yes. Tama
So,
yun.
it's not really the problem of of availability of the preparation kasi nandyan. No, we have the Okay, so thank you, sir. Do you have any other questions for Dr.
Sana
Joey?
naka-deliver tayo sa mga estudyante natin.
Oo naman, sir. We have a very good lecture, sir. So if there are no more questions, I think we can proceed to the next lecture.
Thank you very much.
Thank you, sir.
Thank you very much. Okay, thanks.
Okay, so let's now introduce our next lecturer. For our next lecturer, so he finished his residency training in internal medicine at FEU-NRMF Medical Center. His fellowship training in gastroenterology at the University of the East, Ramon Magsaysay Memorial Medical Center. He's a fellow of the Philippine College of Physicians and a diplomate of the Philippine Society of Gastroenterology and Society of Digestive Endoscopy. Currently, he's the visiting consultant at UERM and FEU-NRMF Medical Center. So let's all welcome Dr. Harold S. Kian.
Good morning. First of all, I would like to thank the section of Gastroenterology for inviting me to be part of this single topic conference, especially to Dr. Alvin Velasco for spearheading this event. Of course, with the support of the section head, Dr. Larry Cham, and the other staff. The topic assigned to me was nutritional assessment, but I included nutritional screening as well on this lecture. So these are the objectives of my lecture. Specifically for this conference, we will talk about malnutrition in acute care setting. To begin with, we have to define what is malnutrition. And unfortunately, there is no single global consensus regarding the definition of malnutrition. Both the American and European Society of Parenteral and Enteral Nutrition, the ASPEN and ESPEN, have stated their definition differently, though both talks and agree that malnutrition is imbalance between what the body needs as to what the body actually receives, whether deficiency or excess. And this imbalance will lead to altered body composition and eventually affecting function. Though this definition is well accepted, it lacks clear and general diagnostic criteria to identify who are the malnourished. Another question is, who then is at risk of malnutrition? To answer the second question, anyone can become malnourished, either undernutrition or overnutrition. For this lecture, though, we will focus on undernutrition. And to partly solve the problem I stated a while ago about the issue on absence of generally accepted criteria for diagnosis of malnutrition, both the American and European Society of Parenteral and Enteral Nutrition have come up with etiology-based diagnostic classification of malnutrition, but primarily focus on undernutrition. Here on this slide, the ASPEN, after identifying those individuals at risk of malnutrition, recognizes that inflammation and severity of disease do play a significant role in malnutrition. So starvation-related malnutrition was classified, and under which are due to hunger, such as seen in famine, patients with chronic and acute disease with concomitant inflammation was likewise classified. So the same etiology-based classification of malnutrition was formed by the ASPEN. So like the ASPEN, disease or illness with or without inflammation was considered in the classification. But then the standardized criteria on diagnosis of malnutrition was still not unified, since both societies have come up with their own set of criteria. It is not until these major international societies realize that a global consensus is needed so that prevalence, interventions, as well as outcomes may be compared throughout the world. Hence, the Global Leadership on Malnutrition, or the GLIM, is formed. This is composed of representatives from the ASPEN, ESPEN, the Federación Latinoamérica de Terapia Nutricional, or the FELANTE, as well as the Parenteral and Enteral Nutrition Society of Asia, or the PENSA. The first meeting was held in January 2016, and after subsequent meetups and discussion among these societies, finally a consensus recommendation was achieved on January 2018. So this is the GLIM criteria for diagnosis of malnutrition. It is a consensus report which involves a two-step model for risk screening and diagnosis assessment. So nutritional screening to identify those at risk of malnutrition using a validated screening tool was the first step. And then this is followed by nutritional assessment for actual diagnosis of malnutrition as well as severity grading. So in here, 5 assessment criteria was included, 3 of which are phenotypic criterion and 2 are considered etiologic criterion. And in order to meet up the criteria for diagnosis, at least 1 phenotypic and 1 etiologic criteria must be present. So severity of malnutrition is based on the phenotypic criteria, while intervention is based on the etiologic criteria. So for the nutrition care process, it involves screening, assessment, and intervention. So malnutrition screening is actually a rapid, simple, and should be validated tool to identify patients of any specific nutrition risk or those patients who already have a clear existence of malnutrition. This screening test can be performed actually by an admitting staff or a community healthcare teams. And this should be performed within the first 24 to 28 hours after the first contact. If the patient was identified to be at risk of malnutrition, then a detailed assessment is needed. If there is no risk, periodic re-screening at weekly interval should still be employed, and then the process then follows assessment if there are any changes of nutritional status. So nutritional assessment, on the other hand, is a detailed, comprehensive approach for formal diagnosis of malnutrition. Screening assesses who are at risk, while assessment actually determines patient's nutritional status. And this includes a thorough history. It includes medical, nutritional, and medication history of the patient, as well as the physical examination. It is also included anthropometric measurements, as well as biochemical and laboratory data. And this should be performed by an expert clinician, a dietitian, or a nutrition nurse. So just like what I've said, for nutritional screening, we have a screening tool which are validated. Here we have the nutritional risk screening, or the NRS 2002, which is used in the hospital setting. It is divided into pre-screening and the other set of parameters for final screening. For pre-screening, it includes 4 questions pertaining to BMI, weight loss, okay, for the last 3 months, dietary intake, disease severity. So any yes answer to any of these 4 questions need further evaluation for final screening. If no to all questions, weekly intervals. But if there is a major operation to be performed, nutrition care plan is considered so as to avoid any associated risk status. Then we have here the final screening of NRS. It includes the documentation of the impairment of nutritional status, as well as the severity of disease. So a score of 0 is given for absence of impairment with nutritional requirement, and subsequent grading, a score of 1, 2, and 3 for mild, moderate, and severe is made. So the total score is with a consideration of age is added parameter. So those patients who are more than 70 years old, additional 1 point is added to the total score. And for the interpretation, a score of more than or equal to 3, the patient is considered to be nutritionally at risk, while those patients who have a score of less than 3, a weekly screening of the patient is done. We also have a screening tool for geriatrics. Okay, this is the mini nutritional assessment. It combines both screening and assessment features. So unlike other screening tool, M&A includes diverse components of both physical and mental aspects that is commonly seen among elderly. Okay, so it also includes anthropometric measurements, nutritional habits, general condition, as well as self-evaluation of this elderly. Then we have the initial mini nutritional assessment of the M&A. This is used as the screening tool. Okay, it consists of 6-item questions encompassing changes in dietary intake, weight loss, physical and neuropsychological condition, as well as the body mass index. The maximum score is 14, while those patients who have a score of less than or equal to 11 is considered possibility of malnutrition. Hence, further detailed nutritional assessment is continued. And then the next slide is the assessment part of the mini nutritional assessment. This consists of 12 more questions, including self-evaluation and anthropometric measurements. Completion of the second part of M&A needs to add the score from the screening, the pre-screening part, with that of the assessment part. And a score of 17 to 23.5 is considered at risk of malnutrition, while a score of less than 17 is considered malnourished. For those patients who are in the intensive care unit, the screening tool used is the nutrition risk in critically ill, or the NUTRIC score. This includes 6 domains to be considered. Okay, this includes age, the baseline Apache 2 score, the baseline SOFA score, the number of comorbidities of the patient, and the days from hospital to ICU admission, as well as interleukin-6. So patients with high Nutrix score have a higher mortality risk. And these are the patients who most likely benefit from aggressive nutritional therapy. If interleukin-6 is not available, a Nutrix score can still be used because it has been found out that it can contribute little to its overall predictive value. So those are the screening tool commonly used among different individuals who are considered or is under investigation if they are nutritionally at risk. Okay, then we have nutritional assessment, as mentioned a while ago. Contrary to screening, is a detailed process which actually provides diagnosis of malnutrition. So this is also the basis of nutritional intervention, which will be discussed by subsequent speakers on each special population under study later on. So again, it includes history, physical examination, anthropometric measurement, as well as laboratory data. So the first part is actually the history. So just like in any clinical investigation, history plays a central role because it's actually the focal point of subsequent steps in the process of evaluation. So you have to take note of patient's subjective symptoms so as to guide the pathways of assessment and then eventually nutritional intervention and overall nutrition care plan. But you also have to consider the possibility of any psychological or psychiatric factors. So you have to take note of that. So what's next in nutritional assessment? The second step is objective physical examination. So through the use of traditional techniques in clinical and physical evaluation, such as inspection, palpation, percussion, and even auscultation. So the goal of which is to detect signs of nutritional deficiencies or toxicities or any hindrance to full nutritional intervention. This includes assessment of muscle mass and subcutaneous fat stores, inspection and palpation of water retention, such as edema and ascites, inspection and evaluation for signs and symptoms of any vitamin or mineral deficits. Part of nutritional assessment is actually measurement of body composition. So by body composition, we mean body compartments which express in percentage depending on the model used. So we have here different model used for describing body compartment. We have the actually one compartment which is composed of body weight. We have the two compartment which is composed of fat mass and fat-free mass. Then we have the three compartment, four compartment, and then the multi-compartment model. So included in the measurement of body composition is the anthropometric measurement. So basic is measurement of body weight and height. Body weight measurement should be standardized to obtain a reliable weight trend. So meaning same time of the day, measurement, and as much as possible, same amount of light clothing. There are also instances wherein we cannot actually measure the height because there are patients who are bedridden and cannot stand. So we can use knee height method, and this can be calculated with a given formula. Then part of anthropometric measurements also is the body mass index, which is weight in kilogram over height in meter squared. It is actually an indicator of chronic malnutrition, and it does not describe body composition, and it does not reliably indicate distribution between lean mass and body tissue. Okay, so we also have skin fold thickness measurements, which is actually an indicator of subcutaneous fat, which mostly account for half of the entire body fat mass and gives information on the energy stores of the body, mainly the triglycerides. So the clear disadvantage of this method is high in their individual variability because age, gender, and ethnicity actually influences the fat mass. So ideally, in order to address the problem, for skin fold thickness should be measured. The biceps skin fold thickness, the triceps, the subscapular, and the suprailiac skin fold thickness. So the total of this score provides a more adequate coverage of the body fat distribution and gives estimate of the total amount of body fat. Another anthropometric measurement is the mid-arm muscle circumference, or the MAMC. It is a measure of somatic protein or a muscle mass. It is calculated by taking a measurement of the total mid-arm circumference of MAC, and then deducting this to layer of adipose tissue based on the triceps skin fold test. So the calculation uses the following formula. We also have another method to estimate lean body mass, the creatinine height index. But several factors influences this method, such as renal insufficiency, meat consumption, physical activity, fever, infections, and trauma. Plus, the tedious collection of 24-hour urine limits its actual use. Nonetheless, values of more than 20% below gender and height adjusted normative values are indicative of moderate to severe protein energy malnutrition. Nowadays, we have new methods available to measure body composition. One of such is the bioelectrical impedance analysis, which is based on electrical conductive properties of the body. The principle is measurement of opposition to the flow of current in electrical term, called impedance. So the current flows easily in tissues containing lack of water and electrolytes such as blood and muscles, whereas fat tissues and body and bone makes it harder for current to pass. But the disadvantage of this method is that it is not recommended in patients with fluid overload and in those patients with extremes of BMI. Of course, in patient in the ICU setting, because it may interfere with electrical devices usually attached to patient. And it is also not recommended for elderly. We also have the dual energy X-ray absorptiometry, or the DEXA, okay, the bone density scan. It is a radiological density analysis, usually employing the hip and the spine. It employs a small dose of ionizing radiation and currently considered by many as the gold standard of body composition measurement. It actually provides indirect measurement of fat mass, fat-free mass, and bone mineral mass. Then we have magnetic resonance imaging, MRI, and the computed tomography CT scan. It allows quantification of fat mass and fat-free mass, and as well it gives information about the fat distribution and enabling estimation of skeletal muscle mass. But due to its limited availability as well as its cost, these are mainly used for research purposes. Same is true with these other modalities, okay? The hydrostatic weighing, or the hydrodensitometry, the airplay displacement plethysmography, the dilution method, the in vivo neutron activation. These are very demanding and expensive methods which are mainly used for research purposes. Another thing to be measured in nutritional assessment is actually measurement of inflammation, because inflammation correlates with disease severity, which then actually and directly affects changes in body composition as well as body function. So some laboratory parameters are included in the detailed assessment for identifying disease severity. So most measured laboratory parameters are full hematological screening. Inflammation actually may cause a drop in hemoglobin, total lymphocyte counts, which are influenced by hypoalbuminemia and other metabolic stress, infections, okay, cancer and chronic disease, as well as liver parameters and electrolytes, and all, of course, the creatinine and urea, as well as vitamins and minerals, are mostly measured for assessment of nutritional status. Then we have serum proteins, which are used for assessment of nutritional status, but these are involved in acute phase response and are actually inflammatory parameters, okay? More than the nutritional status assessment, they actually reflects disease activity. So albumin, due to its long half-life, approximately 21 days, it's actually not a good indicator of nutritional status, but rather, as I've said a while ago, is more closely reflect disease severity and can be used as an outcome predictor, okay, as opposed to nutritional status, because low serum albumin levels are associated with higher rate of complication and mortality. Then we also have transthyretin, or previously known as prealbumin. They have much shorter half-life and may reflect changes in nutritional status. Though like albumin, this can be affected by volume distribution and dilution. So in order to use it better, it should be combined with other markers of inflammatory process, such as the CRP. So in this table, the normal CRP with a decrease in transthyretin reflects impairment of nutritional status, while a normal CRP with an increase in transthyretin means improvement in nutritional status. On the other hand, a decrease in CRP with an increase in transthyretin reflects a decrease in inflammation with or without possible improvement in nutritional status, while an increase in CRP with a decrease in TTR is due to an inflammatory response. So another measurement needed for nutritional assessment is measurement of function. Here it included is the test for muscle strength, which can be done through hand grip strength. Impairment of hand grip strength has been shown to be a good indicator of increased post-operative complication, as well as increased length of hospital stay and a higher rate for re-hospitalization. Cognitive function are likewise included, such as the mood, concentration, and memory. But there is no established consensus on the test that can optimally be used in this setting. For this, we rely actually on clinical impression in most patients group. Then, just like nutritional screening, okay, for nutritional assessment, we also have well-validated nutrition assessment tool. The widely accepted is the subjective global assessment. This tool is based on focus history as well as with physical examination. Included in the history are nutrient intake, weight loss, gastrointestinal and functional impairment, while in physical examination included are loss of subcutaneous fat, muscle wasting, assessment of edema and or ascites. This, however, is graded subjectively, okay, as to well-nourished to severely malnourished. So this is the subjective global assessment questions. 5 features of the history are elicited, okay. So first, we have to consider nutrient intake in relation to patient's usual pattern. So patients are classified as having adequate or inadequate intake. If inadequate, the duration and the degree of abnormal intake should also be noted. Weight loss in the previous 6 months, okay, should be assessed. A less than 5% is considered as a small loss. 5 to 10% is considered as potentially significant loss. More than 10% is considered as significant, definitely significant loss. But you also have to consider here the rate of weight loss as well as its pattern, because there are instances wherein a 10% of a patient's weight is lost in the period of 6 months, but then it regained maybe approximately 3% of his weight in the subsequent months. So there is a net loss of 7%. So comparing to a patient who lost 7% of his weight loss, okay, in the previous 6 months, but continues to lose weight. So the first patient is still considered to be better nourished compared to the next patient mentioned. Okay, so you have to consider also the weight loss as well as the pattern of weight loss. Then we have significant gastrointestinal symptoms, okay, such as anorexia, nausea, vomiting. Okay, by significant, we mean that these symptoms should have been present. For intermittent vomiting is actually not considered significant. Then another feature of this assessment tool is the functional capacity or energy level. So, and then the last feature of the history is the concern about the metabolic demands of the patient's underlying disease. And for the features of physical examination, these are noted as either normal, mild, or moderate, or severe. Okay, this includes loss of subcutaneous fat, loss of muscle mass or wasting, and presence of edema or ascites. So on the basis of these features, both the history and physical examination, the clinician identify the subjective global assessment rank, which indicates the nutritional status. Okay, in order to arrive at an SGA rank, we do not use explicit numerical weighting scheme. Rather, as I've said a while ago, a rank is assigned on the basis of subjective weighting. That is why a clinician or a dietitian that is well adept to nutritional assessment must be the one administering this tool so as to produce reproducible results. Other limitation of SGA though is it gives global answer to the problem, but it does not describe patient's situation in detail. That's why in order to characterize further the degree of malnutrition and the risk of complications related to malnutrition, as well as the need for nutritional support, a detailed assessment process I've discussed a while ago on the previous slides should be done. So those are the history, physical examination, as well as anthropometric measurements, and a detailed examination of the patient as a whole. Okay, so in summary, we have defined malnutrition, okay, which is the imbalance in the state of nutrition, either deficiency or in excess, okay, and this will result in changes in body composition, resulting to poor body function. We have discussed recent GLIM consensus, and we've discussed briefly those persons at risk of malnutrition. We have defined and differentiated nutritional screening from nutritional assessment, and discussed nutritional screening.
Okay. Thank you, Dr. Harold, for that very informative lecture. Hi.
Hello,
Okay,
sir.
so hello. So congratulations on that lecture, Dr. Harold Sikian. So we have questions here from the chat box.
Sir, can you see me?
Yes, we can.
Okay.
Okay. So first question, sir. Among nutritional assessment scores, what is the most highly recommended in our clinical practice? So among the different assessment scores that you've discussed, sir, so most likely, what is the most applicable in our setting?
Assessment tool.
Yes.
Okay. Well, in my lecture, actually, I mentioned the well-validated assessment tool used is the subjective global assessment, but I've stated the limitation of the SGA because it can assess the patient globally, but the detailed assessment of this patient, still you have to rely clinically. And I've also mentioned the other needed methods, such as the anthropometric measurement, as well as the other possible imaging that can be used to assess this patient. So you have to balance, okay, the possible information that you can get from the SGA, and maybe complement it with further assessment with a proper history, physical examination, as well as your other examinations needed. Maybe you might opt to also screen for other laboratory data that can add information to the possibility of the disease severity of these patients that might increase the risk of nutritional decline in this patient. But for nutritional assessment, the well-validated tool is the subjective global assessment.
Yes.
Can you see me, sir? I cannot see myself.
Agree. Then we can see you. Guwapong-guwapo, sir. Okay, one more question, sir. From the presentation, we have seen scoring systems for one aspect of malnutrition, which is undernutrition. So how about the other aspect po, which is overnutrition?
Yeah. Actually, for the purposes of this lecture, I've mentioned that we are focused on the patient and the acute care setting. That's why I did not include the overnutrition, which is usually seen in the community. So you can use some questionnaires. There are some validated questionnaires to assess for overnutrition. As well, there is also a screening tool, the MUST, M-U-S-T, that can be used. Maybe you can just download it on the internet, Google it. So there are screening tool also for those subsets of patients.
Okay, thank you. For the others, if you have further questions for Dr. Harold, I'm sure he will be willing to
I think there's
answer.
also another question here about, yeah.
You can answer them, Dr. Harold, in the chat box. Okay. Okay. So we will now proceed with our next lecture. Okay, so to introduce our next speaker. So our next speaker finished his residency training in internal medicine at the United Doctors Medical Center, had his fellowship training in gastroenterology in FEU-NRMF Medical Center. He's a fellow of the Philippine College of Physicians, a fellow of the Philippine Society of Gastroenterology and Digestive Endoscopy, and currently an assistant professor of the FEU-NRMF Medical Center, an active consultant at FEU-NRMF Medical Center and Pacific Global Medical Center. So let's all welcome Dr. Samuel Uy.
Good morning, Alvin, and for the rest of the participants. Can you hear me? Hello?
Yes, sir. We can hear you.
Okay. Alvin, just to correct the CV, I'm not connected with Pacific Global po.
Sorry. Sorry, my mistake. Thank you.
Okay. Okay, Alvin, can you see my slides?
Yes, sir. Clear po, sir.
Okay. Okay, let's start. Okay. Malnutrition is in the elderly is an under-recognized condition that is increasing in prevalence as the population ages. Malnutrition is a term used to describe deficiency, excess, or imbalances of energy and or nutrient that causes adverse effect on the body and its normal function. Although it can occur at any age, it is most prevalent in the elderly. Poor nutritional status and are well-established negative prognostic indicator in the elderly, especially when it comes to morbidity and mortality. Therefore, an early recognition and treatment of malnutrition is not only beneficial to the patient's health, but also reduce the overall healthcare costs. As the patient or as the people get older, they tend to be more sedentary and their body composition changes, resulting in the accumulation of body fat and decrease in lean muscle mass and extracellular fluid. The body then responds to the need of less energy by decreasing the appetite, or what you know as the anorexia of aging. The weight loss and malnutrition in the elderly are better explained by the 9 Ds of malnutrition, as shown in this slide. Okay. Dementia is a cognitive impairment that results in deterioration of memory, and patients with dementia may have a problem in performing the daily living activities such as shopping, preparing for their food, financial management, and even remembering to eat. This patient usually requires someone to assist or help them to meet their nutritional needs. However, not all patients may have the financial resources to hire a caregiver or have a relative that is available to undertake the task for them. Dysgeusia, or the distorted sense of taste, can be due to a variety of reasons as seen in this slide, from gastroesophageal reflux disease to lead poisoning, to even oropharyngeal problems and chemotherapy medications. They all result in the decrease in the pleasure of eating and the quality of life of this patient, and further adds to the malnutrition state of the patient. Diarrhea, especially chronic diarrhea, may lead to dehydration, electrolyte imbalance, loss of weight, and malnutrition. Common cause of diarrhea in the elderly is the use of laxative. Other causes of diarrhea would be osmotic, secretory, inflammatory, malabsorption, motility, chronic infection, and even systemic diseases. There are many variables that affect depression, such as sex, marital status, the ability to perform daily living activities, and even social interaction. Remember that the depressed patient can be all smiles from the outside, but deep inside still feel and look like this one in the picture. Dysphagia is difficulty in swallowing. It can be due to esophageal or oropharyngeal in nature, either which they can make eating quite a troublesome experience for the elder and contribute to the already malnourished body. Any form of disease can have a negative effect on the nutritional status and contribute to malnutrition, especially in the case of chronic illness. Poor dental condition can result in the inability to chew and eat. That can be corrected by dental care and use of proper dental fitting dentures. However, geriatric patient may not be able to have these financial resources to achieve this. Now, elderly patients suffer from a lot of chronic illnesses, and they may need multiple medication to keep their illnesses at check. This medication can then interact or give undesirable experiences that will decrease the patient's enthusiasm to eat. Dysfunction of the immune system can affect the body in a lot of ways. An elderly patient who has a weak immune system can easily get sick, like catches a cold, that will need an additional energy from an already nutritionally deprived body. Problem with digestion and bowel movement can also prevent the elderly patient from actually replenishing the nutrition that they need. Now, the other aspect that may indirectly affect malnutrition are the availability of food, the financial problems that this patient may have, the living condition, the presence of family support, and social network. Now, sarcopenia derived its word from Greek sark, meaning flesh, and penia, meaning loss. It is a progressive and generalized skeletal muscle disorder that is associated with increased likelihood of adverse outcome, including fall, fracture, physical disability, and mortality. The incidence may be 5 to 15% for ages 60 to 70, and as high as 11 to 50% for patients who are 80 years old and above. In 2018, the European Working Group for Sarcopenia in Older Patients came up with a consensus that the muscle strength is the most reliable measure of muscle function. They then classify sarcopenia as to probable, confirmed, and severe. Studies have shown that sarcopenia can be reversed by a healthy diet and a reasonable resistance and strength exercise. Now, this picture shows how sarcopenia would develop. While this slide tells us the or show us the prevalence of undernutrition in the elderly. It's about more than 10% in non-institutionalized elderly, and about 10 to 50% for elderly who are hospitalized for acute illness, and about 10 to 70% for long care units and nursing homes. Now, despite of the availability of validated nutritional screening tests, many cases of malnutrition still go undiagnosed. To correct this problem, there is a need to increase the awareness among community and hospital-based physicians, and to promote the using of validated screening tests and the creation of nutritional support team in the hospital and institutions. This slide shows the different nutritional assessment screening tool with their scoring system and the years that they are validated. And this slide is a sample of the MNA short form, which is made up of 6 questions. And depending on the answer of each of these questions, they will correspond to a particular point. If you add up all the points of these 6 questions, then you will come up with the screening score. A score of 12 to 14 is a normal nutritional status. A score of 8 to 11 at risk of malnutrition, and a score of 0 to 7 is malnourished. Now, one of the this slide shows the team of the nutritional support team. Okay, they are made up of the physicians, the physician's assistant, nursing practitioner, dietitian, pharmacist, speech and language pathologists, the physical therapists, and occupational therapists. Usually, the nutritional support team is headed by the geriatrician. As for the recommendation, elderly patients should receive regular nutritional assessment. The MNA short form is the first tool of choice for elderly. And we can add the standard MNA, which is made up of 18 questions, to derive a more detailed nutritional assessment. Elder with nutritional risk must have a comprehensive nutritional assessment with an assessment plan. The MNA short form is recommended for an outpatient nutritional screening test for the elderly, while the NRS 2002 are recommended for inpatient screening. Both of these are recommended by the Chinese Medical, Parenteral, and Enteral Nutrition Association. However, the European Society of Parenteral and Enteral Nutrition would recommend the standard MNA for home, hospital, and institution. The MNA is by far the best validated and most widely used assessment of malnutrition. The advantage of the MNA over the other screening tool is that it does not rely on laboratory testing, making it more accessible and easier to perform. The GNRI, or the Geriatric Nutrition Risk Index, make use of albumin and weight as part of their parameters. They can come up with a early diagnosis of malnutrition and predict a 20-day mortality. As for the treatment of malnourished elderly, the food-first approach is the treatment of choice. Patients are given small frequent feeding with high energy and high protein food. They maximize the time of better appetite. They serve the meal in a more appealing way. They can even give the favorite food of the patient and fortify them with fats and sugar to jack up the calorie that the patient may need. Now, if it failed to reach its goal or there is no improvement, then an oral nutritional supplement, or otherwise known as the ONS, can be used. The ONS serve as to top up for food intake rather than for replacement. Therefore, they are given between meals. Nutritional support is given to malnourished patients who are unable to maintain body weight by food intake alone. For enteral nutrition, they can be given through nasogastric tube if the planned enteral nutrition support is less than 4 weeks. We can make use of the PEG or the gastrostomy tube if the planned nutritional support is beyond 4 weeks. Now, if for some reason the stomach is not available, we can probably resort to jejunostomy to deliver the enteral nutrition. Now, there are several formulas used in enteral nutrition. One of them would be the feeding module, which are the single nutrient, either protein, fat, or carbohydrate. They can be used singly or in combination, depending on the need of the patient. Polymeric formulas are also known as the complete balance formula. They would include the blended food, the milk base, or the lactose-free formulas. Okay, and this is the preferred formula to be given for enteral nutrition. There's also what you call the specialized formula for special needs. Patient with pulmonary problem, renal problem, and even liver problem may benefit by using the hydrolyzed or the amino acids. Those patients with heart condition that cannot tolerate big volume of fluid may benefit from the calorie and protein dense preparation, while those patients having a bowel problem like constipation may want to try the fiber enriched formulas. Now, enteral nutrition can give some complication to the patient. First, the tube itself can cause some injury to the nose, pharynx, and esophagus. This can be minimized by using the silicone tube and to try to restrict the using of nasogastric tube to less than 4 weeks duration. The tube itself can also be clogged. Again, this can be reduced by using the liquid preparation, commercially available liquid preparation, rather than the powdered form. The tip of the nasogastric tube can also be misplaced and cause complications. In the case of gastrostomy and jejunostomy, in case they are dislodged, the replacement will be more difficult and more likely to cause complication. This is the reason why for longer enteric nutrition, we would prefer using the PEG. Aside from the tube, complication of enteral nutrition can also arise from the formula itself, causing diarrhea. Therefore, we have to choose the best formula that suits our patient. It can also lead to nutrient imbalances, so that the body weight and the level of electrolytes, glucose, magnesium, and phosphate should be monitored at least on a daily basis on the first week and adjusted accordingly. Even with the tube intact and with the right formula, we can have problems with the reflux of the tube feeding and cause aspiration. This can be reduced by elevating the head of the patient at 45 degrees during feeding and at 1 to 2 hours after each feeding. It's also important to monitor the gastric residual at the end of the 4th hour, which should not exceed 250 ml. For the parenteral nutrition, it can be peripheral parenteral nutrition or the total parenteral nutrition. Now, infection can be minimized if we follow strict sterile protocol during the preparation, the actual insertion, and the maintenance of the catheter. Hyperglycemia is especially a problematic problem in patients who have pre-existing sugar problem prior to nutritional therapy. The elderly patient also have a decrease in insulin sensitivity of up to 43%. So the sudden surge or the sudden increase in sugar that is found in TPN may also contribute to the elevation of the sugar. Blood sugar monitoring and the use of insulin can correct this problem. Hypoglycemia, on the other hand, is due to the sudden stoppage of a high caloric infusion. Sugar monitoring and the use of 50% dextrose bolus may reduce or may correct the transient hypoglycemia. However, for longer duration hypoglycemia, we may need the 5% to 10% dextrose drip to correct the problem. Dehydration and electrolyte imbalance and liver failure can also occur as a complication of parenteral nutrition and should be monitored and corrected. Due to prolonged TPN, micronutrient deficiency and demineralization can occur, leading to osteomalacia and osteoporosis. If present, this should also be corrected. We should also watch out for the adverse reaction of lipid emulsions. Gallbladder complication can also occur due to prolonged NPO. There will be a gallbladder stasis leading to bile sludge and possible stone formation. Thrombosis can also occur, but the use of a low molecular weight heparin might help in this case. Now, in summary, for patients in the elderly, the food first priority is the treatment of choice. We might think to maximize the nutrient-dense energy food for this patient, and we might consider giving multivitamins for patients who ingest or take less than 1,500 kilocalories per day. We would also want to give whole grain, fruits, and vegetables to this patient. If there is no improvement, then we can add the oral nutritional supplement that are commercially available. Remember that the ONS is a top-up for the nutrition and not as a replacement for the main food. If there is no improvement in the nutrition, then we can start enteral nutrition by tube feeding using the complete balance formula. Okay, if the patient will be able to tolerate at least 60% of the total caloric need, then we can continue the enteric nutrition. If not, we might probably consider giving parenteral nutrition. We can compute for the water required at 30 to 40 ml per kilogram per day, the energy required at 30 to 35 kilocalorie per kilogram per day. But for critically ill patient, the energy requirement can go as high as 45 kilocalories per kilogram per day. Amino acid can be computed at 1 to 2 grams per kilogram per day. We also have to add essential fatty acid, vitamins, and minerals as necessary. We choose a solution based on the age and organ function of the patient, whether there is a heart, kidney, or lung condition. If the intended parenteral nutrition is just for short duration, then we can go for the peripheral side. But if it's for a longer duration, maybe we have to consider the central line. We also have to monitor the condition of the peripheral and central line for presence of infection and whether they are working. We also have to monitor for abnormal glucose and control them with insulin. We also have to monitor on a daily basis, at least for the first 24 hours, for the electrolyte imbalance and mineral problem. Hepatic and gallbladder problem can also be monitored on a sequential basis. So with reaction to lipid emulsion, volume overload should not be overlooked, and likewise dehydration. I would like to end this lecture with a quote from Marilyn Ferguson, which states that of all the self-fulfilling prophecies in our culture, the assumption that aging means decline and poor health is probably the deadliest. Thank you for listening.
Okay, thank you, Dr. Samuel Uy, for that informative lecture. For this part, we will reserve the Q&A. So after the third lecture, no? So we will finish all the topics under the nutrition in special populations first. So we'll now proceed with the next lecturer. So to introduce our next lecturer, so He finished his fellowship training in gastroenterology at FEU-NRMF Medical Center. He's a fellow of the Philippine College of Physicians, a fellow of the Philippine Society of Gastroenterology, and a fellow of the Philippine Society of Digestive Endoscopy. So currently he's the head of the section of gastroenterology of the Chinese General Hospital, and he's the past president of the Philippine Society of Digestive Endoscopy. So ladies and gentlemen, so let's all welcome Dr. Jose A. Tan.
Can you hear me? Is it
Yes, sir.
clear? Okay, so pardon my background at the pantry of the hospital. Okay, good morning, everybody. My topic for this morning is about optimizing nutrition and protein intake in critically ill patients in the ICU setup. Right. Okay. So the objective of this lecture is to discuss the issues pertaining to nutrition seen in critically ill patients and discuss nutrition support therapy in patients who are critically ill. These guidelines were taken from the Society of Care Medicine, ASPEN, American Society of Parenteral Enteral Nutrition, and Canadian Critical Care Nutrition, and ASPEN guidelines on parenteral nutrition. So critical illness is often associated with the catabolic and state, and patient demonstrate systemic inflammatory response. Complications such as infection, morbidity, multi-organ failure, hospitalization are expected. Adequate nutrition intervention can lead to attenuate metabolic response to stress and favorable modulation of the response. Prevent further deterioration and the loss of lean body mass and decrease in the decrease in the length of hospital stay and decrease morbidity and improvement of patients' outcome. So this is a very nice algorithm I taken from the practice guideline in India. They have, when the patient is admitted, you check the patient if the patient is hemodynamically stable. If the patient is stable, then you can screen for the assessment of nutrition and calculate the nutrition requirements. However, if the patient is stable, you have to wait for stabilization. Now, why wait? The patients already need nutrition. Why should we wait? So the reason here is that in patients who are hemodynamically unstable, there will be decrease in the peristalsis, which we are commonly referred to as a retention of the gastric substance. And gastrointestinal hypoperfusion will happen, and sometimes mesenteric ischemia can set in on early feeding. For critically ill patients with 2 or more vasopressor in high doses are at risk of developing complications such as gut ischemia, and this may set worse with inadvertent initiating early nutrition. Enteral nutrition should be initiated only when the patient is already on a stable declining dose of the vasopressors and adequate volume resuscitation has been done. In such tropic feeding, giving 10 to 20 ml per hour to initiate patient is the best strategy. Although my technique is I give 50 ml every 2 hours. Okay, but this technique is quite effective in people who are difficult to feed. In persistent shock, early enteric nutrition should be avoided. So enteric nutrition is preferred route of feeding over the parental nutrition for critically ill patient who requires nutrition. And why? Because it maintains GIT structure, it maintains its integrity and its function. It enhances intestinal immune function, and it reduces barrier for translocation and decrease risk of sepsis, fewer complication with parenteral nutrition, and it has a lower cost and it's less expensive. So when should we start feeding? So feeding should be started early, within 24 to 48 hours upon ICU admission. The feeding should be advanced towards the goal over the next 48 hours or 72 hours. The window of opportunity is 24 to 72 hours upon admission, or the onset of hypermetabolic insult will occur. And with this time, there's still less gut permeability, so the leaking gut and diminished activation. Melaine, what happened? Okay, diminished activation and release of the inflammatory cytokines. Then, okay, so here you can see here that when you look at the patient nutritional status, you have to check whether the intestine is functional or not. If it is functional, we can start enteral nutrition. However, in certain conditions, they are not functional, like diffuse peritonitis, intestinal obstruction, intractable vomiting and ileus, intractable diarrhea, and gastrointestinal ischemia. In this situation, enteral nutrition cannot be started. And this is where the parenteral nutrition is started. Now, if the patient has enteral nutrition and you want to know whether this will be a short-term enteral nutrition or it could be a long-term nutrition. By the way, to differentiate enteral from oral, oral is per enteral, we use something inside and we insert a tube or a nasogastric tube, nasojejunal tube, nasojejunal tube. Now, this nasogastric tube are given for these people who has no gastroparesis, while the nasoduodenal tube, transduodenal, nasoduodenal tube, and transvaginal tube are given to people who have gastroparesis, so we can bypass the stomach. And then, for long-term treatment, you can do a PET insertion, tube gastrostomy, or you can use a tube jejunostomy. Okay, so the very, very short demarcation that we follow is that if the tube will be there for more than 2 to 3 months, then we do a tube gastrostomy. But if it's less than 2 to 3 months, we will use the temporary nasogastric tube, nasoduodenal tube, and nasojejunal tube. And if the patient has a good GI function, so you have the normal GI function, we start with the standard nutrition, which Dr. Sami has discussed, the polymeric one. And then after that, we can go for adequate progression of oral feedings. From the tube feeding, we shift to oral feeding. However, in patients who have standard nutrition and there is inadequate, you can only give about 60 to 70% of this total need, then you have to add parenteral nutrition supplement. Okay, and then if the patient did improve later on, then they can progress to a total enteric feeding. In some other patients, they have what you call the impaired compromised GI function. So they have of the food and GT retention. So you have to give this patient special formulas like those with oligomeric type of formula, and then you feed them, and then adequate progress to more complex diet and oral feeding as tolerated. But in case where you cannot start patient with oral feeding right away, and because of this complication, after waiting for 24 to 48 hours, then you can start your patient with parenteral nutrition. And then if you have a short-term parenteral nutrition, you can use short-term, you can use the peripheral parenteral nutrition. When you have long-term, you can use a central parenteral nutrition. So I will be telling you when do you use the central and when do you use the peripheral. What are the difference between the two? And then if the patient GI function returns to normal, okay, then you can start here, come back here, and then start giving your patient standard nutrition or stable specialty formula. While if the patient still do not have improvement of the GI function, sometimes you have to maintain this patient with parenteral nutrition until the patient ICU condition improve. Okay, so early enteral nutrition reduce infection complication versus the late enteral nutrition. So early enteral nutrition means you start patient within 24 to 48 hours upon admission in the ICU. While the late enteral nutrition is after 48 hours time. So you can see that this meta-analysis shows that it favors the early enteral nutrition as compared to the delayed enteral nutrition from the Canadian guidelines. And then early enteral nutrition versus standard support of support on mortality. So will the early enteral nutrition affect the patient mortality? Since we started early, maybe the patient may have some side effect. So this study showed that there is no difference in the mortality in patients who are taking early nutrition compared to the standard support, nutritional support. And when to start parenteral, as I have said a while ago, when your patient is having a poor GI function, then all patients who are not expected to have normal nutrition within 3 days, 72 hours, should receive parenteral nutrition within 24 to 48 hours if enteral nutrition is contraindicated or if it cannot be tolerated. So you don't wait for 3 days before you start this one. But when you assess the patient that the patient is, let's say, post-op patient, you don't expect the patient to be able to be early parenteral nutrition after 24 hours to 48 hours. We can start the patient with parenteral nutrition. Okay, so this one you can see that it's a parenteral nutrition versus standard nutrition, and I can see that there is no influence of parenteral nutrition to mortality. This is a misconception that when you give your parenteral nutrition, your patient is at high risk of having mortality as compared to the standard treatment or oral nutrition. So this was proven wrong with by Haaland, okay, with and then there's overall decrease in the overall complication instead of having mortality. While the Grumlich is discussed or did a study on enteral nutrition versus parenteral. So does enteral nutrition, there's any difference between enteral nutrition and parenteral? So there will be decrease in the infection on complication, and there's no in the mortality. So there's no difference in the length of hospital stay. So this is to allay the fear of people that parenteral nutrition may be harmful, especially in patients who are on long-term parenteral, and some are hesitant to start early parenteral nutrition in case when their enteral nutrition cannot be started. Okay, so this is the summary. So in patient with this type of problem, it is impossible for you to feed the patient even with a tube feeding and a jejunal tube feeding, because this patient is a high risk of getting complication. Okay, you would rather cause this patient harm than good if you start this patient with enteral nutrition. And then so here you can start with a peripheral, parenteral, and central parenteral nutrition. So how do you access? Now, what are the types of access that you want to have? A central venous access to administer high osmolality parenteral nutrition to cover full nutrition need. So when you're giving osmolality of more than 860 milliosmol per liter, then the patient will need a central venous access. Okay, as compared if your patient is going to have short-term parenteral, and you don't have to do a central line insertion, because central line itself can be a complication, and it is also cause high infection rate. So in this type of situation, when you only did for several days, few days of parenteral nutrition, a peripheral access can be done using a less than 850 milliosmol mixture designed to cover the proportion of the nutrition needs and to mitigate the negative energy balance. If peripheral administered parenteral nutrition does not allow full provision, let's say it's not enough, because peripheral they are only giving up to 1,400 calorie in 1,900 cc. So, but the patient will need 2,000 calorie. So then they have to go for a central, no? Needs then should be administered centrally. Put an IJ line or cut down this patient. Okay, you cannot give a patient more than 1,400 calorie in this type of or the osmolarity. The osmolarity is more than 860, then central line should be accessed. So the question is, are we, no, this may be the time Sami, Uy, and me, we have, before we don't have the 3-in-1 bag, no, complete 3-in-1 bag, no, so we don't have that. We have Bamin, 1 bottle of Bamin and 1 bottle of Intralipid, then you put a white tube, then they mix. As they come down, they will mix, no, so, but this is already dinosaur, obsolete. So those who are maybe 50 years old and above had encountered this type of administration. Okay, then you can see that here. Okay, so so that you will not wonder what this Dr. Tan saying. We haven't seen this type of separate parenteral nutrition because of that is previously maybe 20 years ago, but now they have a separate container. Before they have separate containers. Approach, no, requires numerous IV line manipulation, increased rate of administration error, and increased risk of septic and metabolic complication. So you can place Bamin, Intralipid, and then put a white tube there. They will fall. So Intralipid, you can have 200 cc, 250 cc. You can have 500 cc. but this is already history. And they are more expensive than a complete bag, okay? So they are more expensive. So all-in-one in a bag is less expensive than the those one. And then the approach, when you insert one line and then the other line, and then after the interlipid is finished, you remove and then insert another one. There is risk of and so with the present all-in-one bag and one seal only, one-time removal, then we minimize the complication of infection and metabolic complication. Okay, so this is the example of the all-in-one mix, no? So no commercial. Okay, so how much parenteral nutrition should we give? Okay, we have provided energy to close possible as measured by energy expenditure in order to decrease the negative energy balance. In the absence of indirect calorimetry, ICU patients should receive 25 kilocalorie per kilogram per day, and then increasing to the target over the next 2 to 3 days time. This is the ESPEN recommendation. Positive energy balance provides shorter duration of ventilation and shorter ICU stay. Okay. Negative balance leads to increased bacteremia, prevalence, overall complication, and mortality. So these were already proven, and that's why we have to give our patient adequate nutrition to improve our chance of getting out of complication and lower the patient's morbidity and mortality. Okay, so have you heard about supplemental parenteral nutrition? So when do you give it? When do you give supplemental? Okay, in all patients receiving less than their target enteral feeding for after 2 days, so after 48 hours time, you can only give 60 to 70% of the required energy by the patient because the patient cannot tolerate high volume. Then what else can you do? Or the patient cannot tolerate the gastric function is not as good. There's a lot of retention. But when you give a low volume oral enteral intake, this patient can tolerate. So if the patient can only tolerate 60 to 70% of the nutritional requirement for more than 48 hours time, this is the time you will use your parenteral supplement. Okay, so this is a study by Bauer says that enteral nutrition plus parenteral nutrition with a total of 25 kilocalories. So you will add to the diminished enteral nutrition requirement and then compare to the enteral nutrition all along 25 kilocalorie. So what happened? So the results showed improvement in the retinol binding protein and prealbumin, okay, so which is very important for the prognostication. No difference in 90-day mortality. There is no difference in the infection, and it has a little bit of reduced hospital stay compared to the all enteral therapy. So how much carbohydrates? So carbohydrates is the 2 grams per kilogram glucose per day, 2 gram body weight of glucose per day. Now, there is a problem with hyperglycemia, no? And glucose is more than 10 millimoles. It contributes to the death of a critically ill patient, should also be avoided to prevent infectious complication. However, there is a reduction, reduce, and both increase in mortality rate have been reported in patients with ICU when glucose is maintained between 4.5 to 6. So no unequivocal recommendation on this, therefore, is possible at present. Because why is it that these people with a good sugar control has higher mortality? And this is because of the high incidence of severe hypoglycemia in patients who are treated with the tighter limits. That is why, as of this moment, there is no recommendation on how tight you will be, but usually I will be happy with my patient sugar at 140, 160, but not more than 180. So this is my my personal way of treating my patient's sugar, because during the stress, you expect the patient to have a lot of catecholamines coming out, a lot of sugar coming. This patient needs sugar. So when you give this patient high dose of insulin, you push this patient into hypoglycemia, and you know that hypoglycemia leads to more mortality as compared to the patient who have a little bit higher blood sugar. How about lipid emulsion? Lipid emulsion should be integral part of the parenteral nutrition energy to ensure essential fatty acid provision of long-term ICU patient. It's a 1 to 2 grams per kilogram per day by the SPEN. Lipids allow low energy provision from carbohydrates, which facilitate better glucose control. Okay, it decreases fractional de novo lipogenesis, induces slower increase in the sugar and insulin level, and does not increase carbon dioxide as compared to the glucose-based parenteral nutrition. So you know that glucose produces a lot of CO2, and this is no good for patients with, especially with ICU with COPD, because the CO2 retention is not good. So in this situation, lipids work better, and it is the source of the serve as the source of the energy as compared to the glucose. Okay. Now, what types of lipids in a patient with parenteral nutrition? IB lipids that reduces the load of the omega-6 fatty acid with reduce of the load, and soybeans emulsion should be considered. Okay, so you can see here that the reduction in the mortality and reduction in the duration of ventilation and reduction of the ICU length of stay were all significantly better. How much protein do we administer? When protein is indicated, parenteral is indicated, balanced amino acid mixture should be infused at 1.3 to 1.5 ideal body weight per day of conjunction with an adequate energy supply. What is the goal is to provide precursor for the muscle protein synthesis and to protect the skeletal muscle and function. So in critically ill patient, stress hormone and inflammatory mediators inhibit insulin and amino acid anabolic efficacy. So a lean tissue loss is unavoidable in patients with severe trauma, sepsis, despite aggressive nutrition support. How about glutamine? So this is controversial. During our time, that is the advantage of being old. Okay, so my daughter always tell me, "Papa, you're old already." No? So being old, you have encountered glutamine. So I don't think some of you will encounter glutamine, because the glutamine was a recommendation by the SPEN in 2006. And I have been using this for my patient, critically ill patient. So let us discuss what is glutamine. Okay, when the parenteral nutrition is indicate ICU patient with amino acid solution contains 0.2 to 0.4 grams kilogram per day of glutamine. Okay, alanine glutamine dipeptide. Okay, this is marketed as dipeptiben. This is a solo 100 cc bottle to be piggyback into your parenteral nutrition. Okay, so the piggyback silang dalawa. And it actual situation, okay, so how does it help? It has a role in protein and glucose metabolism, conditionally essential amino acid, okay, but becomes depleted in critically ill patient. Supplements reduces mortality and improves morbidity, reduce infection, improve glycemic control, not to be used in critically ill patient with shock and multi-organ function failure. So one of the contraindication is elevated creatinine or renal failure. But in patient without renal failure, I find the glutamine very effective in critically ill patient. Okay, those people who thought that they will not survive So I don't know, but some of the patients that we post-op patient, septic patient, but they are out of sepsis, and then their condition is not improving. When we started this patient with glutamine IV, this patient almost maybe 80% of them survived ICU. So unfortunately, it is very, 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 very expensive. It's about 2,500 per bottle. Okay, so bottles of this on top of your parenteral nutrition. So very few patients, unless that they are so well-to-do, will be able to afford this glutamine infusion. So in ICU, the expense is already very high, and then you have no experience using glutamine, and you don't even know if it's going to work or not. So there is hesitancy. However, if you have encountered difficult to treat ICU patient, those parang wala ng pag-asa. So as long as there is no multi-organ function, multi-organ failure, patient is not in shock. Actually, some of our patients are septic, but they are not in shock. Okay, so then we started this one, and I have very good experience with this one until it is now more available. So I don't know what happened. Maybe because of the expenses. So do we need micronutrients? Okay, so we have micronutrients. Or parenteral nutrition should include daily minimum vitamins and trace elements. But our commercially available parenteral nutrition only contains amino acid, glucose, lipids, and some electrolytes. But for stability reason, no trace element and vitamins or vitamins were included. So we need to give this patient micronutrients. Okay, so and this is with clinical features of common acute trace element vitamin deficiency. What will happen? So you can have thiamine deficiency causes congestive heart failure and lactic acidosis, ascorbic acid, scurvy, copper, arrhythmia deficiency, arrhythmia, immunity, decreased immunity, and pseudo scurvy, and selenium, acute cardiomyopathy, and zinc, delayed wound healing and infection. Okay, in summary, I would like to, Mr. Chairman, I would like to discuss, I have discussed the all critical patient with critical illness and the role of nutrition in their treatment. All critical ill patients should undergo nutritional assessment upon admission. So upon admission, there will be assessment whether this patient will be malnourished, sign of malnourished, cachexia, edema, muscle atrophy, patient with BMI of less than. This is very, very critical if you have to check for patients' sign of malnourished. And enteral nutrition should be started early in patient with critically ill ICU patient, preferably in the first 24-48 hours time when the GI function is working. Do not push the issue if the patient GI function is not yet ready. Do not push the issue. You can cause more harm than good to the patient. In case of nutrition requirement is not met adequately using enteral nutrition, even after 7 days of ICU stay, a supplement use of parenteral nutrition may be considered. Okay, but at the latest recommendation, they give up to 72 hours time. You can start with the supplement of parenteral nutrition on top of the enteral nutrition. You're not going to give pure parenteral. You just give additional parenteral nutrition on top of the enteral nutrition that is lacking. Okay, so nutrition support should be considered as a therapeutic benefit and not a supportive or adjunctive in nature. Do not consider nutrition as just a simple simple adjunct or supplement, but this is supposed to be part of the treatment regimen. And tube feeding is to be considered when 50% to 60% of the nutrition target are not met adequately within 72 hours of oral nutrition support. So in this situation, tube feeding or enteral nutrition should be started. Thank you for your kind attention. Thank
you very much, Dr. Joey Tan, for that very informative lecture. So we will now proceed with our next speaker. To introduce our next speaker, so he had his residency in internal medicine at FEU-NRMF Medical Center, a fellowship in gastroenterology, also in FEU-NRMF Medical Center. He had his fellowship in advanced therapeutic endoscopy at University of Santo Tomas Hospital. He's a fellow of the Philippine Society of Gastroenterology, a fellow of the Philippine Society of Digestive Endoscopy. Currently, he's the head of the Department of Internal Medicine, Hala Valley Hospital, and a core trainer in internal medicine at St. Elizabeth Hospital. So let us all welcome Dr. Angelito, or Dr. Angel Balay.
Thank you, Pong, for that kind introduction. Can you see my slides?
Yes, sir.
Okay. Good morning. First of all, I would like to thank the organizer for this invitation. I got this lecture from the Clinical Nutrition Summit of the PSG and the ESPEN guidelines. Patients with cancer are high risk for malnutrition. Over half of patients presents with weight loss at the time of diagnosis. The prevalence of malnutritions are around 80% in pancreatic and gastric malignancy, and 50 to 60% in colon, prostate, and lung cancer, while 30 to 40% in sarcomas, breast, and hematologic malignancies. Factors affecting malnutrition include your tumor type, the location, the grade and stage of the disease, the age of the patients, the gender, the use of chemotherapeutic agents, and comorbidities like your diabetes and your hypertension. 10 to 20% of patients die due to malnutrition rather than to the malignancy itself, according to ESPEN guidelines. Malnutrition causes longer length of hospital stay, increases cost, produces less effective cancer treatment, and longer duration of treatment, as well as decrease in the survival. Metabolic changes seen in malignancies are due to the insulin resistance, as well as due to activation of your systemic inflammation. Changes like increase in glucose turnover and weight loss are seen in carbohydrates metabolism. There is also increase in glucose intolerance, as well as increase in wasteful metabolic cycle. While protein metabolism, you can see increase in the protein turnover, there is also increase in hepatic protein breakdown, as well as increase in muscle catabolism and impaired protein synthesis. While lipid metabolism, there is an increase in overall lipolysis, and there is an increase in turnover of these free fatty acids and glycerols. These are the different protein mediators and cytokines which alter metabolism. Cytokines can affect the neuroendocrine control of appetite, leading to anorexia. It also increases lipolysis, decreases your lipogenesis, hence there is a depletion of your fat deposits. An example of these glycoproteins, like your proteolysis-inducing factors, your pro-inflammatory cytokines, like your tumor necrotizing factor, your interleukins 1 and 6. Cancer-related malnutrition is a multimodal process. Factors such as impaired in food intake, as seen in patients with esophageal malignancy. There is an increase in energy and protein needs. There is a decrease in your anabolic stimuli, such as your physical activity, and there is an altered metabolism in different organs and tissues. These are the different interventions for management of malnourished patients with cancer. We have your oral diet therapy, your enteral nutrition, parental nutrition, and pharmacologic therapy, as discussed by the previous speakers. Oral nutrition is a simple interventions to maintain nutritional intake despite symptoms in order to regain weight or minimize weight loss. We do this by modifying the amount of food, adding food or oral supplements, or just changing the type of food. Modifications are based on the nature of the GI symptoms. Oral nutritional support includes your regular foods or fortified foods as a meal or a snack, while oral nutritional supplements are the addition of essential amino acids and vitamins. Nutrition provided through the GIT via a tube, a catheter, or a stoma that deliver nutrient distal to the oral cavity. We use enteral nutrition when oral supplementations fails, but there is an intact GI tract. We use this in malnourished patients and those anticipated to be unable to ingest adequate nutrition for a prolonged period of time. As mentioned by the previous lecturer, the benefits of enteral nutrition is to maintain the functional and structural integrity of the guts. It improves your GI and systemic immune function. It is less expensive than the parental nutrition, and there are fewer complications. Ideally, we feed through the stomach, which allows for the use of hypertonic formulas and bolus feedings. An example of this is through your NGT, or nasogastric tube, or your percutaneous endoscopic gastrostomy tube feeding, like this one. We'll now go to the parenteral nutrition. Parenteral nutrition provides nutrients intravenously bypassing the GI tract. These are given to patients who has complete bowel obstruction, peritoneal carcinomatosis, short bowel syndrome, patient undergoing radiation, and of course with patient having chylothorax. We give this to severely malnourished patients unable to ingest or absorb the nutrients for a prolonged period of time. The contraindication, of course, includes your hyperosmolality, severe hyperglycemia, severe electrolyte abnormalities, volume overload, inadequate IV access, and inadequate attempts to feed enterally. Pharmacologic therapy includes your appetite stimulants and hormonal therapy. An example of your appetite stimulant includes your corticosteroids, your progestogens, cannabinoids, and cyproheptadines. While your hormones, there are growth hormones, there are ghrelins, melatonin. Sometimes we give olanzapine, which is an atypical antipsychotic drugs, which blocks your dopamine and your brain receptors. We'll now go to specific diseases, such as your esophageal carcinoma. Patients often present with dysphagia or as a result of the treatment and its complication like post-radiation esophagitis or stricture, post-chemotherapy causing esophagitis or mucositis, or post-surgical vagotomy causing delayed gastric emptying, or patients having insertion of your SAMs leading to acid reflux or pain. This is an example of your esophageal carcinoma and the insertion of your metallic stent. Patients usually would present with dysphagia, and How do we give nutritional support? We avoid possible irritants to this patient. We give small, frequent meals. We give high calorie and protein supplementations. For patients presenting with delayed gastric emptying, we start with low-fat, small, frequent meals. We sometimes may give motility agents such as your domperidons, and we can start enteral nutritions via your gastrostomy or jejunostomy bypassing the esophagus. Patients underwent SEMS insertion. We give small, soft, and moist food. We give small and frequent meals, and we advise frequent sips of liquids. Now we'll go to another problem is your gastric carcinoma. Gastric cancer may present as dysphagia if proximal parts is involved. They usually present with weight loss due to inadequate caloric intake, while complications from surgery would present with early satiety, dumping syndrome, fat malabsorption, and impaired release of these pancreatic enzymes due to obstruction. Complications of surgery depends on the type of gastric reconstructions. We have your Billroth 1, Billroth 2, Roux-en-Y as a surgery. While in Billroth 1, patients would present with dumping syndrome and alkaline reflux. And Billroth 2, patients may present the dumping syndrome, malabsorption, as well as your alkaline reflux. While patients having Roux-en-Y would present with dumping and malabsorptions, and jejunal interposition, you have your dumping syndrome, while ileocecal interposition would present with alkaline reflux. So how do we give nutritional support to these patients? There are two types of dumping syndrome. One, we have the early dumping syndrome, which would present with postprandial diaphoresis, tachycardia, faintness, diarrhea, and crampings. While the late dumping syndrome, around 2 to 3 hours after eating, would present with hypoglycemia, dizziness, and sweating. This is due to the release of your insulin. How do we treat this? This would include intake of small, frequent, calorie-dense meal while avoiding insoluble fiber and simple carbohydrates. Sometimes we give acarbose or octreotides, and we may also start patients on continuous jejunal feeding to lessen the volume. Now we'll go to another problem. We have the pancreatic cancer. Patient would present with cachexia, weight loss in around in Can you hear me?
Yes, sir. Yes, sir.
Okay. So sometimes the patient may also present with pancreatic insufficiency as well as bile insufficiency.
Para na trot daw si Mang. Apa sa LID? Ya di ba dito yung trot pimi? Sina.
So how do we give nutritional support for patients with pancreatic cancer? In patients who had pancreatoduodenectomy presenting with steatorrhea or diabetes, we can start patients on enteral nutrition. For unresectable tumors presenting with gastric outlet obstructions, having ablation therapy or SEMS, we give small calorie-dense meal. For intra-abdominal metastases presenting with intestinal dysmotility, we can give small calorie-dense meal. For unresectable tumors with pancreatic exocrine insufficiency, we can supplement them with pancreatic enzymes. Lastly, we have your colorectal carcinoma. Patients with left-sided mass post-resection rarely causes malnutrition. On the other hand, a right-sided malignancy with involvement of ileocecal valve and terminal ileum may cause watery diarrhea. This is due to the increased amount of bile salts, which stimulate water excretion. We may give cholestyramine to lessen the diarrhea by binding the bile salt. For final words from the PSG guidelines, if the gut works, use it. Thank you.
Okay. Thank you, Dr. Angel. So I think in the interest of time, we will forgo with the live Q&A, but I'm sure if you have any questions for our speakers, please type it in the chat box, and I'm sure they are all willing to answer your queries. Okay, so let's now proceed with our next speaker.
Thank you.
Okay, so for our next speaker, so our speaker had his residency training in pediatrics at the FEU-NRMF Medical Center, had his fellowship in gastroenterology and nutrition at the Philippine General Hospital. He's a fellow of the Philippine Pediatric Society Incorporated. He's the past president of the Philippine Society of Pediatric Gastroenterology, Hepatology, and Nutrition. Currently, he's an associate professor of the FEU-NRMF Medical Center and an active consultant at FEU-NRMF Medical Center. He also heads the section of Pediatric Gastroenterology, Hepatology, and Nutrition at the Philippine Children's Medical Center. Let's all welcome Dr. Randy Ortula.
Hello, ako na ba? It's my turn. I'm ready na? Okay. So, hello everyone.
Hello, good morning, sir. You can start sharing slides,
yes,
sir.
of course. Okay, we'll start. So good morning, everyone. And I would like to thank the organizers for this, for inviting us as well. And of course, greetings from the Department of Pediatrics and to all our listeners out there. Good morning and welcome to this lecture on nutrition in the sick and hospitalized pediatric patients. You know, we're going to take up a very important aspect in the management of sick children that is often more or less neglected, and that is nutrition. Particularly for our small patients, these are quite crucial, particularly in the management of their illness, and of course, faster recovery. Now, these are my disclosures that might affect my discussion of this topic, but however, I do not intend to discuss any of the commercial products that they are putting out in the market. Okay, I begin my lecture with a quotation from the famous, of course, the father of medicine, Hippocrates. Okay, let food be thy medicine and medicine be thy food, because all diseases actually begin in the gut. Now, our objectives for this lecture are to know the unique nutritional challenges of acutely ill and hospitalized children, and now understand the role of enteral and parental nutrition in the sick and nutritionally at-risk children, and for you to be presented evidence on how both of these forms of nutritional support can actually benefit the sick child. Okay, so we all know for a fact that malnutrition among hospitalized children is quite common, and it is very particularly in high prevalence in those children who are admitted at the PICU. And being malnourished is associated already with an increased morbidity and mortality that now, of course, increases the chance of dying, because anyone who has associated malnutrition can increase the risk of dying from a particular condition. Now, this is due to the fact that they have an altered metabolic status and metabolic response for the injury and illness. And therefore, some of them results to high requirements of energy, particularly on proteins and other nutrients. Now, the prevalence of malnutrition in the past 50 years has not changed. If you can see, from the 1980s until now in 2020, the prevalence ranges from about 12 to about 25%. And this is known for a fact because although there's malnutrition and the science is there already, the clinicians actually fail to recognize on how to manage these children and usually pay attention only to their medical problems and not actually also with the malnutrition that goes with it. Now, malnutrition in hospitalized children has reasons for further deterioration of their nutritional status. Number one would be the effect on the disease itself. Number two would be some of the drug nutrient interactions that you give your patients. For example, in giving sodium or your diuretics, you lose a lot of sodium and potassium as well. No? There might be electrolyte and micronutrient deficiencies that you do not recognize, particularly if you are not adept at identifying the signs and symptoms of vitamin deficiencies in children, as well as, of course, there's an effect on the gastrointestinal motility and function, and not to mention also some of the diagnostic procedures that may require fasting, like, for example, what we do in children, your esophagogastrodinoscopy and even colonoscopy, no? And even your simple ultrasound, some of your patients are put on NPO for quite some time, no? And sometimes you may be missing out on the delivery of your nutrition for this sick child in the hospital, no? We're quite only what they call this complacent of giving them their IV fluids, just because even though if they're only on NPO. Now, the effects of your inadequate nutrition is quite very much, particularly in your immune system. It results now into your immunosuppression, and this might actually make you susceptible to nosocomial infections that happens in your hospital. There's also poor wound healing and reduced gut function. And sometimes the inadequate nutrition may impair the function of certain organs, particularly the critical ones, leading to your multi-system organ failure. And as have been mentioned by the previous lecturers, there might be prolonged ventilator dependency because you now fail to recognize that you're giving too much carbohydrates in these patients, which is converted into carbon dioxide. It has also been shown that if you are malnourished or you supply inadequate nutrition, there is a longer length of stay in patients who are admitted at the ICU. Now, on immunity, it is very important that you are nourished because malnutrition affects almost all of the levels of your immunity, from cellular up to your humoral type of immunity. No? It may also result into a reduced mucosal integrity and the delayed development of your thymus and other immune system that may help you fight off infection and maintain your immune system. Now, you would note also that your different nutrients also have an important interaction with your immune system on different levels. For example, your micronutrients zinc, iron, selenium, and iodine has an effect on your antibody production, as well as your omega-3 fatty acids, as had been mentioned earlier. It has now been shown to decrease inflammation, favoring now tolerance rather than inflammation. And there are a lot of other nutrients that are found in your body that can help also in antibody production, as well as promoting healthy bacterial flora that might now increase immunity in your GI system. So our goals for nutritional support for the acutely and chronically ill child are the following. The first, we want to prevent or minimize the catabolism that has already been going on. But however, we want to promote anabolism for growth. Okay, whatever lean body mass we should try to preserve, because we don't want to get them become thinner and thinner because of their disease illness without feeding. Now, we must able to be maintain as well the intestinal absorptive and immune function and the barrier function of our GI tract. We must also be able to reduce the risk of your protein calorie malnutrition, and therefore it improves now the patient outcomes, particularly survivability on particular critical illness. Now we have two forms of nutrition in these critically ill and even your hospitalized children. One is enteral and the other is parenteral. Enteral nutrition means you are able to nourish the child using your gut, no? And this may include the use of your regular diet, your oral supplementation, and if you are also feeding them with regular diet, however, via tubes that you place in the child, no? It's either a nasogastric tube or nasojejunal or even a PEG, what has been mentioned earlier. On the other hand, your parental nutrition is actually nutrition using your peripheral veins, no, and even the central veins, wherein some of the nutrients are concocted or they are mixed together and are being placed in your IV sites. Now, a lot of studies has been shown to compare your enteral and parenteral nutrition in children. It has been shown that your enteral nutrition is more physiologic and therefore more affordable and easier and safer to administer. It has been shown to produce fewer metabolic and infectious complications. Now, because you are feeding or using the gut, it can now better support integrity of your gut barrier function, as well as provide trophic effects to the gut. And that now gives you an effective prophylaxis against GI bleeding as well as gastropathy. Now, the good thing about enteral nutrition is that you can place a lot of other nutrients that can complete now the range of nutritional elements that you need in your nourishment of your child sick. So therefore, in studies have been shown that enteral nutrition is actually the one that is recommended as a first-line therapy for those who are critically ill, since it's favor now the alteration of outcome of these children, providing for both nutrition and non-nutritional benefits, such as you have fewer infectious complications, and of course, earlier gut function, and the non-nutritive ones would be the reduced cost and a significant reduction in the length of stay in the ICU. Now, when you say enteral feeding, it means two things. Either you are using an enteral oral feeding by special formula, or number two would be any type of food that is being delivered by any tube or stoma that is placed into the patients, either surgically or endoscopically, as you see in these pictures. Now, the clinical indications for pediatric enteral nutrition are the following. No? If you have inadequate intake, there are any disorders in the digestion and absorption, there's an increased nutritional requirement or losses. Also, you have growth failure or chronic malnutrition that you can supplement, as Dr. Joey said, no? You can also supplement them with your parenteral as well as enteral nutrition. If you have any altered metabolic or inborn errors, so we use special formulations for them that are available in the market, as well as for the primary disease management. It's tailored fit to what disease. No, for example, has been mentioned earlier, for cancer, for a pulmo patient, for a cardiac patient, or even a renal patient for that matter. There are several contraindications to enteral feeding though, and of course there are usually the ones that has something to do with the GI tract. No? For example, in children or infants, you have necrotizing enterocolitis. Or if you have perforation or gastrointestinal obstruction, no? It's a no-brainer. No? If you have major intra-abdominal sepsis or peritonitis, and even in severe shock, wherein there might not be any more good circulation in the GI tract, and that might cause problems later on in your patient. Now, how do you select now the right enteral formula for these types of patients? First of all, the nutrients and energy requirements should be adjusted on the particular needs of your patient. So it's not the cajon, no? It's tailored fit to what your patient needs. So in pediatrics, we compute it using your weight. No, you have also considered the presence of any food intolerances or allergy. For example, if your patient is allergic to soya or even to your other allergens like peanut or even your eggs, no, for that matter, you have to consider them because these are now reactions that take place in the body and might now affect the absorption of your nutrients. Consider also the level of your intestinal function. No? If it's only partial or there is a big chance that there is malabsorption, then you might consider the use of certain pre-digested milk formulation. No? Consider also the site and the route of delivery. No? For example, if you are delivering your enteral nutrition in the jejunal area, now it requires now an extensively hydrolyzed formulation because of what the digestion is not much complete when it reaches your small intestine. No? So consider also the osmolality and viscosity of your formulation. No? This might now have a bearing on how you feed your patient. No? And lastly, taste preference. But if you bypass the mouth, there is less stimulation of your taste buds, and therefore this is not much of a problem. However, the next thing would be the cost and availability also of your formulation. Now, enteral formulations in children come in three forms, no? And you consider the age. You can use for less than 1 year all the infant formulas available in the market right now, no? They have their own dilution depending on the manufacturers. But for the 1 to 10 years of age, we use pediatric formulations. And for those 10 years and above, we consider them already as adults. I can use now the adult formulation, no? And specialized formulas and other supplements are available in the market right now, particularly for certain conditions in children. And as have been mentioned also before, we have also modular additives for children like your glucose polymers or maltodextrins, and we have your MCT oils as well as your other nutrients and electrolytes and even protein solutions. Now for the pediatric enteric formula, nutritionally, it's a nutritionally complete formulation that can maintain growth of children during the acute and chronic illness. So these pediatric formulations are quite essential in their care. And do not forget that you should give them if the child can be able to use the GI tract. These enteral formulations can protect as well from infection because they are adequate and now stimulates your immune system and can now protect you from other infections that are present during periods of acute and chronic illness. Now, being able to use your gut also promotes gut health because you are now able to maintain the integrity of your GI tract as well as promote the development of your normal commensals that can help fight off infection. No? And this can now minimize the complications of your enteral feeding that can assure you some safety and feeding tolerance. So, in these types of cases, we use pediatric enteral formulations that are nutrient dense, to support growth and development and improve your healing. And what you know is just if you can add just clean water. So it's really simple, no? And it's available in the market. And that you can easily prepare, no, and instruct your patients during time of illness. Now, why are infant formulas not appropriate for older children? Now, we all know for a fact that infant formulas are not nutritionally adequate for those older kids because these are tailored fit to the needs of infants, meaning less than 1 year old or 2 years old. Because these infant formulations has too low calories and of course too low in protein and even in vitamin minerals that are needed by the growing children or older kids. No? So that's why we are not advocating this to be used for more than 1 year of age. On the other hand, how about adult formulas and why not just dilute them and use them for kids? No, first of all, children are not miniature adults, no? And the formulations for adults are actually designed for their needs to address specific nutritional needs, no? And in this case, for children, if you use the adults and then you dilute it, the vitamins and minerals there are too low to meet the pediatric needs. And therefore, if you dilute them, you actually dilute also not only the minerals, but also the macronutrients by half. For example, you now dilute also your carbohydrates, your fats, and even your proteins, no? Some of the adult formulations also has a very high solute load that can lead to excess nitrogen and lead to elevated renal solute load that challenges the pediatric kidneys, particularly the infants wherein their kidneys are not yet that mature, no? And for most of the pediatric formulas, they provide only about 12, no? As compared to adults, which has higher protein, no? Content, about 16 to 24% of the total energy intake. Also, the long-chain fatty acids, which is essential for the brain development and eyesight development of children, it seems to be lower in those older formulations, and therefore it's not able to meet the growth and development of these children. Now, you have heard a lot of blenderized formulations. Ito yung nakikita natin sa atin sa ospital, ano? And it is viewed as actually the original form of nutritional support. And it has been seen because it's more natural because you give the nutrition coming from the whole foods or the real foods. However, there are certain concerns that must be taken into consideration when giving your blenderized tube formulations. Number one is the possible contamination of these blenderized foods with organisms if the environment is not clean or the utensils are not clean and hygiene is not very well practiced. Or if the storage is not complete, for example, in the refrigerated area, and it is left to stand out, no, then you have problems now, no. That's why we do not advocate giving blenderized formulations to children in more than 4 hours because that is what is known as the maximum hang time, no, of your enteral formulation, so that there would not be much growth of this bacteria, no. Also, you cannot actually compute for the amount of your energy macronutrients being delivered to your patients. And in fact, in a lot of studies, it has shown that it only delivers even less than 50% of what you actually put in the patient. I must remind you that the term is blenderized, no, not anymore. Mga students natin, no, interns, clerks, and even residents, no, the term is blenderized, not austerized feedings. No, Auster is a brand of your food processor. So pag naging Molinex yun, Molinex na tube formulas, that's not it, no? So the generic term would be blenderized formulations or tube formulations. On the other hand, when do you use parenteral nutrition, no? Parenteral nutrition is actually the intravenous administration of nutrients in a concentrated form were you able to maintain metabolism and promote your tissue synthesis, no? These are actually specially designed for those patients who cannot use the GI tract because of some surgical or medical conditions that you can have in your patients. And there are two forms, the total and the partial, no? The total for children, which means you do not use any part of your GI tract, no? So all of them, the nutrition comes from your IV, no? However, when you use the term partial parenteral nutrition, it is actually the simultaneous use of your enteral and your parenteral route to supply the nutrient needs of your patients, no? And you can see here in the space. So if you use both the oral partially and even your IV, that is what is known as partial parenteral nutrition. But total, you don't use anything from your GI tract. Some of the indications for use of your parenteral nutrition in pediatrics would be the following three categories, no? You have problems in the oral and enteral route of feeding. You have incomplete food absorption, and then of course, oral intake is not advisable. For those with feeding not possible to the enteral route, some of the examples are your short bowel syndrome because you have been operated on for necrotizing enterocolitis. You have malignancies that affect the oropharynx and even anywhere in the GI tract, which is quite common in children, particularly your lymphomas. You have CNS trauma because of an accident and the patient is unconscious or comatose. So how can you feed them orally, no? For incomplete food absorption, there are a lot of malabsorption syndromes, and the usual ones can be seen in prolonged diarrhea. So therefore, sometimes if they cannot tolerate the oral intake, your what they call this supplemental parenteral nutrition may be needed, no? And of course, you have certain illnesses that can affect the GI tract, particularly inflammation, because we have what is known also as pediatric Crohn's disease. The oral intake is not advisable for certain post-operative conditions, like for example, in the GI tract mainly, no? In the newborn, you have gastroschisis or ruptured omphalocele, you have mid-gut volvulus or even impepperate anus. In those cases, then you should try first parenteral nutrition, and when you have prepared the patients for surgery, and when the surgery is done, you try to initiate early enteral nutrition. Now, you can have both, no, peripheral and central veins for your peripheral nutrition or parenteral nutrition. For your parenteral nutrition using the peripheral veins, there are certain requirements, no? It is used for short term, meaning to say less than 2 weeks ating ano, no, yung when you're using your nutritional support, no? And the dextrosity should not exceed 12.5% of the total. There's also a low osmolality, no, should be, no, because only the small veins cannot tolerate all of the higher dextrosity and higher osmolality, and you may cause IV burns, and that means it's a problem later on, no? And although it's associated with lesser complications, then it must be preferred, no? However, for the central lines, these are quite used, particularly if you're going to feed your patient on a longer period of time. We have seen a lot of cases here in the other hospitals wherein we put your percutaneously inserted central catheters, no, for chemotherapy as well as feeding these patients, no. And for patients, these are the ones that being used for feeding more than 2 weeks. So we have home parenteral therapy for children who are with cancer. So we use these kinds of larger veins, no. And with this one, with the larger veins and higher flow of blood, you can now have higher dextrose concentration, even to about 20% or 30% of your total, no, caloric requirement, no? So instead of being D5, becomes D30 or D15 or something like that, which the large vessels can tolerate, but not your smaller vessels. Now with this one, you can now deliver higher osmolality, no, because it is being diluted by the high flow of blood, and of course the complications of high osmolality is less. Now in lipids in pediatrics, we also use lipids, no? And usually there's now a mixture of your egg phospholipids, your plant-based lipids, no, your soya, your sunflower oil. So it's a combination actually, no. And some of this has been shown to be effective, particularly in lessening inflammation. Now, previously, as Dr. Joey said, no, if you are 50 years and above, no, you have encountered this in your the hospital, no, wherein we use the 2-in-1 system, wherein the one bag contains two elements, your carbohydrates and your proteins, no, together with the electrolytes and multivitamins. And the other bag is actually your lipid, no. And the advantage of this one is that it can provide flexibility, no. So it's not anymore, no. You can adjust the dose of your amino acids and even the dextrose. You can add your other macronutrients. You can increase the dextrosity, no. At the same time, see the precipitation because the bag is separated, no. They only meet in the Y tubing, as have been mentioned earlier, in the piggyback system. However, one of the disadvantages would be the flexibility of the type of lipids that you can give in these patients, no? We prefer giving your 20% lipids per patients, no, because it is metabolized better as compared to the 10% lipids, no. And I don't think it's available right now anymore, yung 10% and 20%, because now they're using another system, which is actually the 3-in-1 system, no? Parang kape, no? 3-in-1 na, all mixed na no sila, no? It's what is known as your total nutrient admixture. We also use that in pediatrics, no? It's actually a complete parenteral nutrition composed of all the macronutrients. It has already the dextrose in one bag, no? You can see here, the dextrose in one bag, the amino acids here, and this one is your lipids, no? And then, of course, with sterile conditions, using, of course, glove, nakagown din kayo, no? Now you can roll that up, and then once the bag, no, the barriers here are ruptured, they mix together, no? And then you just agitate it a bit, no? and you can give them now as one solution. Okay, the multi-chamber bags are given in one solution. However, they require an inline filter because some of the precipitation happens as well during the time when they mix, no, particularly calcium and other electrolytes. So in these types of your system, it now improves your hospital ergonomics. What is hospital ergonomics? No, it can now improve your services. No, it lessens now the amount of people that you hire for preparation of your parenteral nutrition. It removes the other equipment such as, so for example, your laminar flow hood, and of course the stocking of your other nutrients, for example, the electrolytes, your vitamins and minerals in your pharmacy, no? Because it comes in 3-in-1. No? We use this particularly for older children because for younger children less than 1 year old and even for infants, we usually still concoct it because the requirements are quite strict and it's computed on a per weight basis. That's why we still use the concoction method. No? And this one now designs particularly the amount of nutrients that are needed on a per kilogram basis, which are for your smaller kids. But for the older ones, you can use this one. No? Previously, the pediatric preparation of your 3-in-1 system is available here in our country, no? But when they started producing the big bags, no, and one company bought the ones that makes the pediatric formulation, they stopped the production of your pediatric, no, 3-in-1 system, no. So we make do with the adults, the ones that we use, no. So 3-in-1 system that has a 1,400, 1,000 calories, no, depending upon the needs of the patient, no. Now I saw a question earlier in the chat box that says na what if, no, if we cannot, usually in children you can actually supply all the needed nutrients with the available 3-in-1 solution. However, the thing is it's quite expensive for them, no, because if you have consumed already the amount or the volume that you have computed for that particular patient, you discard the rest. Now, we give this parenteral nutrition on a 24-hour basis. Again, the hang time is there because we don't want to promote the growth of your bacteria in that nutrient-rich solution. So we also give them a rest. For example, instead of 24 hours, we give it 20 hours only, the total computed parenteral nutrition, because we want to give a rest time or what we call cycling, no, of about 4 hours in between your parenteral nutrition so that there will be more metabolism of your lipids as well. So in pediatrics, do not forget your nutrition, either by enteral or parenteral. No? For enteral nutrition, as long as you can use your GI tract, go for it. No? But for those patients, if you cannot feed them within the next 7 days, as been mentioned also in the previous lecture, you should now try to plan early on giving them your parenteral nutrition. No? And if, of course, you can only use your gut partially, then you can go with your supplemental parenteral and enteral nutrition. So as I end my lecture for today, we know for a fact that malnutrition in hospitalized children is quite still common, and it's not much managed, no, and even neglected. No? And this can now lead to increased morbidity and mortality, especially among those who were previously malnourished and having a chronic illness. Now, the key is actually the appropriate and early use of your enteral formulations to minimize mortality and morbidity. So it means it improves now the outcome of your patients, improving the health of your sick children. It has been proven also that your enteral nutrition is a safe and effective method in giving your nutritional therapy to sustain growth and development, even in those childs, particularly if you have a preserved gastrointestinal function. Of course, lastly, your enteral nutrition is actually very essential to the management of these children. It should be integrated into the daily care of your patients while hospitalized or when you are dealing with a sick child. And early and careful planning of your parenteral nutrition should be done in these patients, particularly in whose surgical or medical conditions prevents them from using adequately their GI tracts to receive nutrients. So if you have questions, again, I'm Dr. Randy Urtula, a pediatric gastroenterologist. Thank you for listening and good day to all of you.
Thank you very much, Dr. Urtola, again, for a very wonderful lecture. In the interest of time, we will have to proceed to our next lecturer. If you have questions for Dr. Urtola, you can type it in the chat box and Dr. Urtola can answer them. So to introduce our next speaker, had his residency training in internal medicine at the United Doctors Medical Center. He had his fellowship training in gastroenterology at East Avenue Medical Center. So he's a fellow of the Philippine College of Physicians, a fellow of the Philippine Society of Gastroenterology and Digestive Endoscopy. He's an assistant professor at the FEU-NRMF Medical Center and also an active consultant at Fedel Mundo Medical Center. So, ladies and gentlemen, let's all welcome Dr. Roy Caballero.
Good morning. Today I'm going to talk on fad diet. Are we familiar with this pop-up advertisement during our online shopping? Well, this topic aims to refresh ourselves of the fad diet. What does it do and guide us to spot suspicious fad diet that may not necessarily be beneficial for us in the long run or may be even harmful? Wikipedia defines fad diet as a diet that is popular for a time, similar to fads in fashion, without being a standard dietary recommendation and often promising unreasonably fast weight loss or nonsensical health improvements. Sometimes fad diets are demonized because it is unfounded and no solid scientific evidence. This may help us check if we can ask questions like, does it ask you to eliminate one or several food groups or promise quick results? They also use several personal testimonies as proof of effectiveness or use only certain foods that offer special advantage for weight loss or recommend supplements or pills as part of the plan. Sometimes it is advertised by a celebrity and when exercise is not regarded as important. This and more are telltale signs of a fad diet. I'm not going to talk individually in detail on each diet, but I will just pick some of the common ones that we encounter often. There are certain diets that are proven effective and I'll try to clarify their role and their intended purpose. How do we differentiate now a fad diet from a true diet? This will become a challenge since every group, whether advocacy or just a plain commercial value, will introduce us to a new way on how we perceive food. Our judgment will be based most of the time by the outcome they show us, personal testimonials, or scientific papers circulated as the result of a certain diet. Convincing as it may, we are trapped again in the soundness or unsoundness of their claim for that matter. How often we hear news from certain medical association, local and abroad, advocacy groups, nutritionists, agriculturists, and the like, who made several revisions, amendments of the process that is different from their original claims of a certain diet. This just gives us a notion that there is no such perfect diet. Most are emerging, if not incipient. I have stumbled on my readings this chart about the history of fad diet. Even then, people were already desiring for a healthy life, whether for weight loss, stamina boosters, or just feel good, look good reasons. The need to be healthy evolves over time from control of blood pressure to lower blood sugar levels or even prevention of Alzheimer's and so on. But most of the indication is the desire to lose some weight. Highlighted are some bizarre practices like the urine diet. that can be used therapeutically mostly by alternative medicine practices for inducing weight loss. We have the tapeworm diet during the Victorian era. Tapeworm diet became the fad, especially in young women. A patient will ingest a pill with tapeworm eggs until it hatches, grows, and eat whatever the host eats. This is very controversial if this existed at all, since it's very laborious to place a tapeworm eggs in a pill. Cigarette diet. Nicotine is a natural appetite suppressant, thus leading others to consider smoking a viable diet plan. The most likely route of this diet plan is a cigarette company. In 1925, the Lucky Strike cigarette company capitalizes on nicotine's appetite-suppressing abilities, effectively creating the first cigarette diet. The Sleeping Beauty diet. It involves taking sleeping pills with the goal of sleeping through normal waking hours to avoid eating, also referred to as narcorexia. This fad diet is not only ineffective but also dangerous, especially increase the risk of all manner of dangers and problems due to impaired brain function while under the influence of the pill that may lead to car accidents, accidents at home, and in the workplace. All these diet fads shown are obviously dangerous and not physiologic. Now, you are going to start on a new diet plan. Be careful. We have discussed already what are the hints that this may be a fad diet. Don't fall prey on those promising diet. If it sounds too good to be true, it probably is. Giving you a promise of a 30-pound loss in 30 days? That is tantamount to a gastric amputation. Let's look at this common popular diet and what others have to say on them. From a periodical, Diet and Nutrition, South Beach Diet is designed by a Florida-based cardiologist, Dr. Arthur Agatston, who wanted to protect his patient from serious medical conditions like heart disease and diabetes. The South Beach Diet is one of the popular diet that stresses the importance of controlling hunger by eating before it strikes. Dieters are urged to disrupt the typical hunger, overeat, gain weight cycle by cutting out bad carbs and focusing on lean protein, low-fat dairy, and good carbohydrates, that is, whole grains, vegetables, and fruits. The first phases of this diet are strict. The third is the maintenance phase. It's meant to be a lifelong eating plan that allows you to enjoy occasional treats while maintaining a healthy weight. Weight Watchers Diet, or WW. It has evolved over the years, but this popular diet's fundamental beliefs have remained the same. Eat a balanced diet, eat in moderation, and eat what you want. The diet uses a point system to track down what you have eaten and provides a motivation through a local support meetings with weigh-ins, or dieters can attend virtual meetings online. Though the high level of flexibility and temptation can be difficult for some, Weight Watchers Diet has had a great track record of success for more than 40 years and remains one of the most popular diet today. Mediterranean diet, composed generally of fish and vegetables with a glass of red wine. This heart-healthy diet includes the food staples of people in countries surrounding the Mediterranean Sea such as Greece and Italy. It emphasizes on heart-healthy fats, those containing unsaturated fats and omega-3 fatty acids. The diet is rich in seafoods, nuts, legumes, fruits and vegetables, whole grains, and olive oil, as well as red wine in moderation. The Atkins diet is a low-carb diet usually recommended for weight loss. Proponents of this diet claim that you can lose weight while eating as much protein and fat as you want, as long as you avoid foods high in carbohydrates. It is split into 4 phases. We have the phase 1 up to phase 4, induction phase, balancing phase, fine-tuning, and maintenance phase. During the induction phase, you have to eat 20 grams of carbohydrates per day for 2 weeks. Eat high-fat, high-protein with low-carb vegetables like leafy greens, and then until you reach the maintenance phase. Here, you can eat as many healthy carbs as your body can tolerate without regaining weight. As with many other diets, the main idea is to stop eating foods made with refined flour and sugar, but even nutrient-dense whole grain foods are off limits until you reach the maintenance phase. Atkins' diet continues to evolve. Now, it encourages eating more high-fiber vegetables, accommodates vegetarian and vegan needs, and addresses health problems that may arise when beginning a low-carb diet. The Paleo diet. In its purest form, the Paleolithic diet, more commonly known as the Paleo diet or the caveman diet, allows only those foods that humans ate when we first roamed the planet 500,000 years ago. Paleo diet typically includes lean meat, fish, fruits, vegetables, nuts, and seeds, foods that in the past could be obtained by hunting and gathering. The paleo diet limits foods that became common when farming emerged about 10,000 years ago. This food includes dairy products, legumes, and grains. The paleo diet has gained positive praises among fans who say it helps them not only lose weight but get and stay healthier. However, experts say the long-term results aren't proven and the diet is difficult to maintain. Raw food diet. Advocates of the raw food diet believe that cooking food and thereby breaking down its enzymes destroys many of its nutritional benefit. Restricting food to raw items or food that is cooked or heated to no more than 118 degrees Fahrenheit, this fad diet plan allows you to eat as much as you want, as often as you want, as long as it is raw and vegetarian. Nutrisystem. The premise of this diet is simple. Eat 6 small meals per day to help prevent hunger, theoretically making it easier to lose weight. By limiting the calories in your meals, you can lose weight via calorie restriction. To make this process easier, Nutrisystem provides pre-made meals engineered to deliver only a certain amount of calories per day based on your age and gender. These meals are either frozen or shelf-stable but fully cooked and only requires reheating. Nutrisystem also provides shakes that you can use for snacks. The major drawback is the cost of a packaged meal. Intermittent fasting is a form of time-restricting way of eating which involves consuming food during an 8-hour window and avoiding it or fasting for the rest of the day. It is the perfect way to schedule your daily meals to get most out of them. Keto diet. The ketogenic diet is a very low-carb, high-fat diet that shares many similarities with the Atkins and low-carb diets. It involves drastically reducing carbohydrate intake and replacing it with fat. This reduction in carbs puts your body into a metabolic state called ketosis. When this happens, your body becomes incredibly efficient at burning fat for energy. It also turns fat into ketones in the liver, which can supply energy for the brain. Ketogenic diet can cause significant reductions in blood sugar and insulin levels. This, along with the increased ketones, has some health benefits primarily used to manage seizure in children with epilepsy. These are the basic principles and assumptions of these popular diets. Are we ready to join the crowd to get the optimal effects they promise to give us? Although there are good effects one can observe in this diet, issues on sustainability, long-term effects, and physiological compatibility are just one of the few questions posted. This diet, as we know, will impose different restrictions and rules to give us the desired result we want. Looking at the core, their basic commonality is to reduce the caloric intake in totality, whether from carbs, fats, dairy products, or timed fasting. This will be overall good starting point for the induction of discipline on the will of the willing. There is a large study in one article published in European Society of Cardiology in 2018 pointed out that low-carb diets are unsafe and should be avoided. A large study concludes that a low intake of carbohydrate raises the risk of premature mortality as well as mortality from several chronic illnesses. Therefore, scientists urge dieters to avoid low-carb diets. The author, which is Professor Banach, said that low-carbohydrate diets might be useful in short term to lose weight, lower blood pressure, and improve blood glucose control. But our studies show or suggest that in the long term, they are linked with an increased risk of death from any cause, and death due to cardiovascular disease, cerebrovascular disease, and cancer. They try to examine the links between low-carb diet and the risk of premature mortality as well as mortality from specific chronic diseases. The possible mechanism underlying the correlation between low-carb diet and death, he noted that animal protein and specifically red and processed meat has already been linked with increased risk of cancer. He said, the reduced intake of fiber in fruits and increased intake of animal protein, cholesterol, and saturated fat with these diets may play a role. Differences in minerals, vitamins, and phytochemicals may also be involved. In the battle of ratios, whether high or low carb, or high fat, low fat, or the type of fat that matters, a group of researchers at Harvard T.H. Chan School of Public Health, Boston Children's Hospital, and colleagues in 2018 came to a consensus and a future research agenda. The researchers agree that no specific fat to carbohydrate ratio is best for everyone, and that an overall high-quality diet that is low in sugar and refined grains will help most people maintain a healthy weight and low chronic disease risk. They agree that by focusing on diet quality, replacing saturated or trans fat with unsaturated fats, and replacing refined carbohydrates with whole grains and non-starchy vegetables, most people can maintain good health with a broad range of fat to carbohydrate ratios. When we try to Google top 5 healthy diet, we will likely to see one of these diets. We can have Mediterranean diet, paleo diet, low carb whole food diet, vegan diet, and so on. The striking similarities in this diet is the absence of processed food and promotion of whole food and low sugar. From there, we can read the pressing problems our society is having today. They are all generated to stave off overweight problems and cardiovascular diseases. If we can bring these problems under control, then we can expect a significant effect on our health. Since most of these diets provide only short-term observable effect in our body, The long-term results still remain to be seen. Here we are talking not only control of hypertension or blood sugar levels. Much of people are focusing on wellness, quality of life, longevity, etc. A book based on observation of the healthiest person on earth. Their lifestyle speaks clearly for the overall facets of wellness. For example, the blue zone. What are blue zones? Blue zones are regions of the world where it is claimed a higher than usual number of people live much longer than the average. The time or the term first appeared in his November 2005 National Geographic magazine cover story, The Secrets of a Long Life. The tag places that are inhabited by healthiest people are Japan in Okinawa, Sardinia in Italy, Nicoya in Costa Rica, Icaria in Greece, and among the Seventh-day Adventists in Loma Linda, California. As you can see, diet is just part of the whole wellness big talks. The other aspect of wellness pertains to relationship or sense of community, sense of purpose, engagement in family life, and engagement in spirituality or religion. Now, where do we go? Gleaning from the presentation above, the Mediterranean diet, South Beach diet, blue zones, and the like, which obviously tells us that there is no superior diet over the other, or no diet that fits all because some of us have unique profile and medical issues. One thing that stands out, they oppose eating of processed food, sugary foods, and stresses on whole grains, fruits, vegetables, nuts, legumes, seeds, and spices, and having meat sporadically, and majority are fishes and lean meat. Can you still remember that those food groups are the recommended content of our table food ever since our medical days in our textbook? Or a familiar words used by our parents or even our lolas that keep on poking on us during our lunchtime? Still, it is the same. Constantly changing are our habits, lifestyle, and our food preferences. I think more than the absolutes, a general guiding principle is better available at our side. No food is evil as long as we do not corrupt its natural state and eaten in moderation and consider our health background. Diet is tailored to the medical condition of the individual. Any diet that reduces the number of calories you eat can help you lose weight as long as you stick with it and listen to sound science. We cannot afford to be ignorant in this high-tech world when information is at our fingertips. Our health is at high stake. Health becomes a reality when we apply wisdom in every sense of our choices, use our common sense, and work with our heart. Thank you.
Thank you very much for the very informative, very nice slides, Sir Roy. Thank you very much. Okay, so
Thank you.
we'll proceed with our last lecture for this single topic conference. So to introduce our our next speaker, okay, so he finished his residency in internal medicine at the FEU-NRMF Medical Center, had his fellowship training in gastroenterology, also in FEU-NRMF Medical Center. He's a fellow of the Philippine Society of Gastroenterology and Digestive Endoscopy. He was a past member of the Specialty Board of the Philippine Society of Gastroenterology, a past chair of the Accreditation Board of the Philippine Society of Gastroenterology. Currently, he is an assistant professor of the FEU-NRMF Medical Center and an active consultant at St. Luke's Medical Center Global. So let's all welcome Dr. Arnold Vito.
Hi, good morning, Pong. Thank you.
Good morning, sir.
I would now like to know if nasi-share ko na ba yung screen ko? Am I okay, Pong?
Yes, sir.
See it? Oh,
You
sorry.
can see your slides.
All right. Okay. So good morning, Pong. Thank you very much for that kind introduction. And I would like to greet everyone a good day. First of all, I would like to congratulate Dr. Cham and Dr. Velasco for organizing this symposium on nutrition. And of course, I would like to congratulate all the speakers. And I would like to thank everyone who's still here about to listen to my lecture. Thank you very much for sticking with us. So why do we, are you still seeing me, Pong? Is it okay? Yeah.
Yes, sir.
Okay.
Yes, sir.
Okay. So why do we give appetite stimulants? Well, we usually do it or give appetite stimulants because we are concerned about the patient's appearance. We think that the patient is malnourished or the patient is losing appetite. So it is a perception that we have in regards to our patient. So loss of appetite is simply a means of, or loss of appetite simply means a loss of desire to eat. Now, this in turn may lead to weight loss, poor nutrition, weakness, and affect a patient's quality of life. And ultimately, of course, it may really lead to a malnutrition. Now, appetite stimulants are medications, supplements, or any substance that increases a person's feeling of hunger. And ito mga substances na to, these substances, we term them as orexigenics. Pong, there seems to be a problem. Wait, I will forward. Yeah, okay. So, it is important to determine whether a person has a decreased appetite. And I think, usually it's a knee-jerk reaction. First of all, I think what we need to know is, how come that person has a decreased appetite? Is that person suffering from stress, depression, as mentioned by the other lecturers a while ago? And of course, does the patient have cancer? And we all know that cancer is very notorious for decreasing a person's appetite. Does the patient have GI disorders like an ulcer, an inflammatory bowel disease, or GI malignancies? Does the patient have chronic disease such as COPD, Parkinson's, or Alzheimer's? It was stated that Alzheimer's and Parkinson's may actually initially manifest with a loss of appetite. And of course, in patients with heart problems, chronic infections such as tuberculosis may also cause loss of appetite. So we also have to remember that as we age, of course, our metabolism starts to slow down. And of course, when you have a decrease in activity level, your appetite or your hunger tends to become less. And hormonal changes also affects our appetite. Now, with regards to children, what causes children to lose appetite? I remember as a child, of course, diba? We were forced by our parents also. Reverse naman to with what Dr. Caballero said. We are forced to eat too much because they think we are too thin. Or we are not exposed to a particular type of foods when we were young. So I think now we have more knowledge that we have to give different types of textures to encourage our young ones to have a better appreciation of different types of food once they grow old. And of course, sometimes some children would like to drink milk or juice between meals, and that of course leads to fullness before a regular meal. And of course, it may also be due to a developmental desire for autonomy, early feeding difficulties such as colic, may mga bagong babies dyan, katulad ni Dr. Sakian, alam nila to, yung colic, frequent vomiting, di ba? Can also affect the appetite of children. Genetic predisposition, I was surprised, of course, to find out that there are actually studies showing twins who have poor appetite, and it was genetic in nature. An unstructured or highly variable mealtime practice may also affect the appetite of the child, and the delayed introduction of solids past 9 months may also affect a patient's or the patient's ability to eat solid foods in the future. And of course, when eating, diba, in a family where there's a lot of argument, a lot of stress in the dining table, of course, that I'm sure everybody would lose his appetite when people are fighting in front of the dining table. So we also have, I forgot to add, of course, in among adults, there may also be other reasons, very simple reasons. And I think this one is very, it touches base because I have this personal experience with my father who had dental problems. And his appetite was very poor because his dentures were ill-fitting. And it was very painful for him to eat food. Maybe it's as simple as that. So we have to find out first why the patient or our patients have a decrease or a decline in their appetite. Okay, so I'm going to discuss some of the common appetite stimulants. So I would just like to ask for your pardon. I would like to ask for your pardon since I cannot discuss all of the products that are listed as appetite stimulants. So when you look at when you Google it and you look for appetite stimulants, what comes out are the Chinese herbal medicines, and you can actually buy this at Shopee and Lazada at any time. So I will just discuss those that are commonly seen in our medical practice. Okay. So first of all, it's thiamine or vitamin B1. Is the main components of an appetite stimulant. It is known as a cofactor in carbohydrate metabolism, the Krebs cycle and the pentose phosphate pathway. And it is also involved in blood formation and nerve transmission. And there is no definite proof that it stimulates appetite. But of course, correction of thiamine deficiency does lead to improvement of food intake. A study done on 44 set of twins, ages 7 to 15 years, demonstrated that thiamine supplemented twins were not superior to the unsupplemented twin with regards to height, weight, manual dexterity, or retentive memory. And I'm sure you also encounter cyanocobalamin as another common additive to appetite stimulant formulations. We all know that this is required for myelin synthesis, and it's also involved in DNA synthesis. And a lack of vitamin B12 may lead to development of megaloblastic anemia. I'm sure you remember that in our lectures, basically because, again, it affects the DNA synthesis. A report on nutrition by the American Academy for Pediatrics showing no benefit of vitamin B plus folic acid supplementation among premature infants. Same results or conclusions were arrived at by Finberg and Chow in a study of 54 premature infants who received 30 micrograms of vitamin B12 daily and 63 unsupplemented premature infant control. And they found out that there was no beneficial effect with regards growth. So at this point, the evidence for stimulating or growth promoting effect as well as the appetite stimulating ability of vitamin B12 is not as convincing. Lysine is also a component among appetite stimulant formulas. It is an essential amino acid, as mentioned earlier by Dr. Joey Santos. It is said to be important for growth and muscle turnover. It is also used for carnitine, for the formation of carnitine. And we all know that it's marketed, right, as a fat-burning substance because it facilitates the entry of fats into your cells. Niacinamide or nicotinamide is a form of vitamin B3. B3 deficiency can lead to skin disorders, kidney disorders, and even brain disorders. And a footnote is that niacinamide is not the same as niacin, but both are types of vitamin B3. So chlorella is also a popular component and comes from freshwater green algae. It contains proteins, vitamin B12, iron and vitamin C, and it contains antioxidants. It also contains some vitamins and minerals. Plus, it also has some omega-3 content. And if taken in large quantities, of course, it provides with some fiber. Cholecalciferol, or vitamin D3, is of course important for calcium absorption. The recommended daily allowance is usually 600 international units for those aged 18 to 70 years and 800 international units for those 70 years old and above. Now, this is a short list of drugs that decrease appetite on the left and drugs that stimulate appetite on the right. I will be discussing some of the drugs listed here as appetite stimulants. Okay. So please allow me to read 3 comments on appetite stimulation by the American Geriatric Society. First of all, there are no FDA-approved drugs available for the promotion of weight gain in older adults. A minority of patients receiving mitrazapine report appetite stimulation and weight gain, and I will be discussing this in a short while. All drugs used for appetite stimulants, I think this is very important. All drugs used for appetite stimulation have substantial potential adverse events. So megestrol actually is one of the appetite drugs that has demonstrated a statistically significant increase in appetite. In this study, amongst 45, I think, women patients who were malnourished after discharge from a hospital were given 200, 400 milligrams, and 800 milligrams of megestrol, and some received placebo. Now, it showed an increase in the prealbumin levels at day 20. But at final assessment, 63 days after, only those with 400 milligram dose maintained a statistically significant increase in prealbumin. And a big however is that there was no significant improvement in serum albumin or clinical endpoints like weight, functional status, or health-related quality of life. A Veterans Administration study, this time predominantly male patients, demonstrated a statistically significant increase in appetite. It showed also an increase in weight of about 4 pounds, and I think they gave the drug for about a few weeks, about I think 12 weeks, and then the problem is that 12 months after post-treatment, only 9 of the 26 patients had a sustained weight gain in the megestrol group as compared to 7 of the 25 in the placebo group. Megestrol is one of the most widely used orexigenic drugs. Loprinci et al. Demonstrated that megestrol improved appetite amongst cancer patients. The weight gain was 16% in those treated with megestrol versus 2% for those who were given placebo. A recent meta-analysis revealed that 25% of those taking megestrol will have improved appetite, and 1 in 12 will have improvement in their weight. So megestrol is a progesterone, and it might be a consideration to our patients with cancer, HIV, or anorexia. Please remember to monitor for side effects like stomach upset, mood changes, development of blood clots, and worsening diabetes, because it may be necessary to give it for long term, and please avoid giving it to patients who have clotting tendencies because of the tendency of the drug for patients to develop venous thrombosis. So going back to that, remember I mentioned mitrazapine a while ago, and so we will see mitrazapine as an appetite stimulant. So a pilot study which assessed the effect of mitrazapine on cancer patients showed a trend towards improved appetite. And at 7 weeks, this was at 7 weeks, although this was not statistically significant. It also resulted in improved weight and mood symptoms. But we have to remember, no large trials have evaluated its effect in cancer-associated cachexia and anorexia. We must also remember that mitrazapine is primarily an antidepressant, and the increase in appetite is more of a side effect of the drug. And please note the other side effects shown in this slide on the left side. So what more is that I think we should take heed of this warning from the NIH regarding the use of mitrazapine, that patients taking it are prone to having suicidal thoughts or tendencies. Steroids are known for appetite stimulation and has been known to palliate cancer-associated loss of appetite. It also adds a sense of well-being for patients who take it. One study comparing dexamethasone to megestrol revealed that both drugs were similar in efficacy. However, dexamethasone had a higher discontinuation rate due to its toxicity. Oxandrolone is a steroid shown to help people to gain weight post-surgery, trauma, or chronic infection. Its side effects, of course, is same as those with other steroids. And for those who really like to take marijuana, tronabinol is a man-made form of tetrahydrocannabinol, which is found in marijuana. It has been used to treat anorexia in AIDS patients. Dronabinol has also been used to treat nausea and vomiting amongst cancer patients. And dronabinol is actually useful as a patient to control nausea and vomiting when other medications have been tried without success. So Childs et al. In a phase 3 study compared cannabis extract rather, to tetrahydrocannabinol among cachectic patients. The results showed no significant differences among the different interventions. So it has also been shown that dronabinol is inferior to megestrol in terms of appetite improvement and weight gain. Anamorelin is an oral ghrelin, and we know that ghrelin is a hormone in the stomach which stimulates the growth hormone. So they found out it's a mimetic, demonstrated some palliation of anorexia amongst lung cancer patients with advanced disease. It is actually a promising intervention, probably in the future. It's not available clinically at the moment. There are several or exploring its utility as an appetite stimulant in the future. Now, cyproheptadine is a first-generation antihistamine associated with weight gain amongst healthy and unhealthy populations. One trial loss among cancer patients. A tumor-specific benefit, however, was seen if you give it to patients with metastatic carcinoid tumors. A systematic review by Harrison, citing 46 articles, showed 39 studies demonstrated cyproheptadine resulted in significant weight gain. Studies exploring the use of cyproheptadine for malignant and progressive disease like HIV and cancer showed minimal to no benefit. An RCT by Najib done in Iran had a positive finding on increased BMI amongst children with mild to moderate nutritional or undernutrition, and this was given for 4 weeks. I recently read an article again, it's not in the slide. It's again an Iranian study on cyproheptadine showing that it showed benefit in height and weight gain amongst patients or children who have growth hormone resistance or deficiency. So this is an article for the malnourished by Charles Medawar. So I purposely erased the brand and the drug companies cited in this article. So his first contention was that the benefits cited by a drug company in Pakistan with regard to cyproheptadine were two irrelevant and questionable papers. He further states that cyproheptadine was recommended as an appetite stimulant for children, adolescents, and adults by the drug company. However, the US FDA withdrew approval for its use as appetite stimulant and for children and was never approved as an appetite stimulant for adults by the FDA. So in the Philippines, pisotefen is one of the substances used for drugs marketed as appetite similar to cyproheptadine. It is used in Europe mainly as prophylactic treatment. It is used in Europe mainly as prophylactic treatment of severe and recurrent vascular headaches. Its side effects would include drowsiness and increased appetite with weight gain. It is said that this increase in appetite and drowsiness are mild and diminish with prolonged use. So again, citing the article by Charles Medawar on appetite stimulants, he argues that the drug company sells pisotefen to many third world countries as a different brand for weight gain. On the other hand, this same drug company markets this drug for migraine among first world countries, but gives it a different brand name. So he further highlights how the company twists the storyline, saying pisotefen is highly effective with very good appetite stimulation when promoting it as an appetite stimulant. But when it was promoting it as an anti-migraine medicine, they state that there might be a slight increase in body weight. And this warning is written in smaller fonts. In Europe, pisotefen is marketed as Sandomigran and is indicated preventive treatment for migraine. In the US, it is medicine for migraine. But note that the drug is no longer available in the US. So the last drug I will be discussing is buclizine. It is an antihistamine. And this letter to the editor I came across, published in the Indian Journal of Pharmacology, shows that the author seems to have no love lost for buclizine. And he states that it has been tried as treatment for allergies, motion sickness, migraine, etc., with no success. It is being promoted as an incredible appetite stimulant. The trial using the drug are just 3 trials and are underpowered. No other trials were done for almost or for more than 20 years. So their PubMed search failed to come up with the literature indicating buclizine as used as an appetite stimulant. And no standard pharmacology textbook was encountered by the author that mentions buclizine as an appetite stimulant. So making a long story short, it was banned in India. And I'm sure it sounds familiar, no? Something that's banned, but despite being banned, buclizine is still being sold as an appetite stimulant. So the Health Action International, or HIA, is a consumer coalition which is campaigning against the promotion of appetite stimulants. And to quote their statement, the temptation to promote drugs to achieve weight gain is great, if only because fear of malnutrition is an established part of life. The exploitation of this fear is what the promotion of these drugs is really about. End of quote. So there are 2 things that the author pointed out. First, appetite stimulant encourages myths and more so among third world countries where regulation of medicines is limited. Reduced appetite or below average weight may not be medically significant at all. Second, even in cases of malnutrition, it is important to treat the underlying cause and investigate the underlying cause and not the symptom. In children and even amongst the elderly, a loss of appetite could be a warning that that patient may be suffering from an infection. So these are just some suggestions to increase appetite without having to resort to giving medications. Number one is exercise or an increase in activity, which may boost hunger levels since you increase the body's need for fuel. Planning and preparing for meals may be important. So small frequent meals may be better tolerated by the patient. Identify the time of day that a patient's appetite is greatest and feed that patient during that period of time. Try to encourage snacking even when the patient is not hungry. Encourage snacking by putting fruits, nuts, and other nutritious food visible around the house. And ask help from someone who is knowledgeable in planning and preparing good meals. So choosing the right food is important. Avoid the patient with high fiber, low-calorie foods at each meal. So a good example is that in patients with, let's say, partial obstruction of the colon or those with colon cancer that are not yet obstructing, we keep on asking them to eat vegetables. But, you know, the benefit of the vegetables and fiber is already too late. The patient has cancer. It's more beneficial to feed that patient with more nutritious food to cope with the increase in demand or fuel that the patient would need to fight the cancer and to survive or to handle the treatment like surgery and the chemotherapy. So add fruits and milkshakes and desserts to boost flavor and the nutritional content of what you're giving. So you can try giving smoothies, protein shakes, or high-calorie nutritional supplements, like mentioned by others, to increase the nutritional benefit that the patient will get every time they have the appetite, every time they have the urge to eat. And of course, you have to find out how they like the food prepared. Like some like it hot and some like it cold. So we cannot force our patients sometimes to eat a hot meal when drink. In summary, I would just like to say that there might be some usefulness of drugs in certain situations to be given as appetite stimulants. But of course, we have to remember that these drugs have side effects. And we also have to remember that sometimes the drugs we give, the effect of appetite stimulation is just a side effect of that drug. Identifying the reason for loss of appetite is essential in finding ways to alleviate it without the use of drugs. The drugs we give to increase appetite are not without undesired effects. So we have to carefully monitor our patients when we do indeed have to give it to them. Appetite stimulants might need to be given for a long time. So again, monitoring is very important because it might take a long time before you can see visible effects. And search to appetite without having to resort to medications as a first option. With that, I would like to greet you in advance. Merry Christmas. Maligayang Pasko po sa lahat and salamat sa pakikinig nyo and for appreciating our conference. Thank you.
Thank you very much. So, as usual, a very superb lecture, Dr. Arnold. So, thank you. I think all of our participants, our audience are already hungry. So, before we officially close the program, may we call a representative from Abbott, our partner from the pharmaceutical company, for a few words.
The most powerful force to maintaining a good immune system is the power of positive thinking and not allowing yourself to be unnecessarily drained emotionally by worries and fears. And for almost 9 months now, most of us are still wrapped in worries and fears. It is time for us to fight back, stop worrying, and be strong. Good morning. My name is Donnie Angsico, your partner from Abbott Nutrition International, the makers of pioneering solution in medical nutrition. For the next 10 minutes, allow me to share with you on how we can help you manage your patients in improving the nutritional status and have a stronger immunity. A study by Putacheri in 2013 has shown that normal muscle loss in 10 years is up to 8%, a 10-day inactivity is up to 5%, and a 10-day in the ICU results in an 18% muscle loss. Muscle loss is associated with complications from impaired immunity, a 10% loss of muscle mass, and as muscle mass loss increases, it leads to higher risk of mortality. Up to 77% of patients with severe and very severe COPD have vitamin D deficiency, and up to 20 to 40% of COPD patients have cachexia. Loss of muscle mass and strength impaired immunity are linked to increased risk of infections. Patients with sarcopenia have 2 times higher risk of developing nosocomial infections. Sorry po, Doc. Share screen ko po ulit. Sorry for that, Doktora. Ayan. Only Ensure Gold has the unique combination of HMB and triple protein blend that helps build and preserve muscle mass and strength. Ensure's protein sources are whey for fast protein due to its metabolic rate, soy for intermediate, and casein as low protein. The combination of these 3 protein sources is what we call triple protein blend, and that provides a prolonged and sustained availability of amino acids. Ensure Gold is rich in nutrients needed for normal immune system function. It has vitamin B6, B12, and iron, which are essentially physiological and neurological functioning. It has vitamin C and selenium, antioxidants that strongly influences the immune response to inflammation due to aging or illness. Vitamin D that modulates innate and adaptive immune responses. Zinc to regulate immune cellular functions such as cell growth, differentiation, and survival. And of course, triple protein blend, essential for the production of antibodies and immune cells. Early oral nutrition supplement intervention within 24 hours of hospital admission improves recovery outcomes of our patients. From the study of flu in 2015, it shows that there is a 51% lesser risk of hospital complications. In another study by Sriram in 2017 shows that length of hospital stay is shortened by 26%, and the chance of readmission is 29% lower. So therefore, we cut down the cost and burden for patients, and in your end, makes admitted patients more manageable. I also want to share with you another study by Deutz in 2016 that only Ensure Gold with HMB is clinically proven to help decrease post-discharge mortality by 50% from 9.7 to 4.8 in hospitalized patients with cardiopulmonary disease. Also, with the number needed to treat compared to aspirin, which is 333:1, Ensure is 20:1. That is 17 times lower than aspirin. The same study also showed that giving Ensure Gold with HMB improves the nutritional status of patients with cardiopulmonary disease after discharge by 52% and 2 times more weight gain in 90 days. He also measured the hand grip strength of these patients, and it showed that there is an improvement in hand grip strength by 2.5 times more. Deutz also measured the serum albumin with the cardiopulmonary disease post-discharge in 60 days and has seen 23% more serum pre-albumin and 20% more serum vitamin D. Therefore, we can say that Ensure Gold improves the nutritional status of your patient. Some of us may think that all ONS in the market are the same. So let me share with you that only Ensure Gold with HMB is clinically proven formulation with a true value for money. 100 peso per serving consists all of these: HMB, triple protein blend, 3 times more vitamin D, choline to improve memory and other cognitive functions, 28 vitamins and minerals, and we are backed up by clinical studies. Now, that's value for money. I am sure, being a physician, you would always choose the best for your patients. By the way, we also have our Ensure Loyalty Rewards program wherein they can use in all Mercury drug outlets and enjoy discounts that are higher than senior citizens or PWD cards. For nutritionals, our senior citizen and PWD cards only get 5% discount, while the Ensure Loyalty card, they get 10%, and if they register, they can get higher discount of up to 12%. Ensure Gold with HMB is available in different variants such as vanilla, chocolate, and wheat flavor. SKUs available are 150 grams for trial pack, 400, 850, 1.2, and 1.6. And introducing the newest member of the Ensure Gold with HMB family. I know you're excited to hear this. Yes, Ensure Gold is now available in coffee and strawberry. Yes, how about that? Let us spread the good news to our patients and let them taste the goodness of Ensure Gold with HMB and coffee and strawberry flavors. I am pleased to have presented to you how Ensure Gold with HMB can help you in managing your patients and improving their nutritional status and have a stronger immune system. We have HMB, triple protein blend, and a complete and balanced nutrition with 28 vitamins and minerals. Our claims are backed up by clinical studies and is worth paying for, plus they get to enjoy discount when using our loyalty card in Mercury. Abbott has been helping people live their lives by keeping them strong and healthy for over 125 years. And the key to that longevity and success has been the willingness to adopt and respond quickly to the changes in the world around us. I hope that this presentation will help us free our minds from the worries and fears and will again start to live our lives to the fullest. Again, I am your territory manager, Donnie, reminding everyone to cheer up, stay safe, and stay strong.
Okay, thank you very much, Donnie. Okay, so to formally close our conference this morning, may I now call again the Section Chief of Gastroenterology of FEU, Dr. Larry Cham.
Thank you, Pong. Okay. In behalf of the Department of Internal Medicine and Section of Gastroenterology, I would like to thank all our distinguished lecturers and speakers who took time from their busy schedules to share their expertise in the field of nutrition. Special thanks to Dr. Joey Tan, our mentor, and Dr. Angel Balay, all the way from Gensan, Mindanao. And to all our very own GI consultants like Dr. Arnold Bitug, Dr. Randy Urtula, Dr. Sam Uy, Dr. Roy Caballero, Dr. Joey Santos, Dr. Harold Sikian, and of course, not to forget our overall coordinator and chair in this single topic conference, Dr. Pong Velasco. Thank you also to Dr. Ellie Dait, Dr. Joyce Sumangit, and all our consultants from the Department of Internal Medicine and Section of Gastroenterology for gracing our conference, and all the residents from the Department of Internal Medicine headed by Dr. Charm Acuña. Last but not the least, I would like to thank Mr. Charles Guansing, DSM, and Donnie from Abbott Pharmaceutical for their support in this endeavor. Thank you all for your support and attendance, and may God richly bless us all and keep us all safe and healthy. To Him be all the glory. Till the next GI conference, thank you everyone for coming. Thank you.
Download from Google.
This concluded our conference for today. Thank you, everybody.
Okay, thank you.
Thank you, everyone. Thank you.
Congratulations. Thank you.
Thank you.
Thank you, everyone. Salamat
Thank you,
po.
everyone.
Dr. Tantochong, salamat po.
Thank you po. Thank you.
Thank you po. Thank you po.
Thank you, Alvin. Thank you, Alvin.
Thank you po. Thank you po.
Sir, please
Doc Joey,
stay on for
please,
our
picture taking.
Wala akong video.
Walang video ako?
Oh,
Tingnan na kita, video.
Nasa group
Yes,
chat
sir.
ako.
Kita na.
Yan. Video.
Pakay kasi.
May procedure kasi.
Picture taking, mga staff.
Picture taking.
Muna.
Okay.
Teka.
Paano ba mag-picture taking?
I-ano natin.
Uy, nandito. Thank you very much to all our speakers.
Thank you. Congratulations for the learning.
Doctor.
Thank you.
Thank you.
Bye-bye.
Huwag ka muna nga alis, Angel, kasi kunan muna natin ng picture. Saan si Edmond? Joey, Dr. Joey Santos, mag-ano.
Wala po akong video, doktora.
Hala ka.
Disable.
Bakit, sir?
Bakit ka naman walang
procedure si
video?
sir.
Disable ang akin. Disable.
Doon sa may video.
Pangalan mo. Ano ba yung pangalan mo ng brother yung nandiyan?
Yan.
Yan, oh.
Sami. Ngayon lang.
Teka muna, picture taking na.
Sami.
Oh.
Doc Joey.
Yes, sir.
Ano na lang, grid na lang siya.
Hi, sir.
Hanap buhay pa eh.
Hanap buhay
pa ako.
Tindi niyo, sir. Grabe, hindi talaga kayo nag-cancel.
Oo, isa-isa muna.
Hindi, tinapos ko yung lecture bago ako nag-schedule.
Sa'yo, tapos naka-video ko eh. Cellphone.
Thank you.
Okay na.
Teka muna, sir.
Group, sir. Group picture taking.
Oh, grabe. Oo nga. Magawa ka na ng multiple.
Group hug.
Para naman group picture be taking.
Gawin nyo yung grid. Yung grid view.
Okay.
Tapos, open nyo
yung group picture taking. Paano ba?
Game.
Yan. Oh.
Group picture taking.
Doc Arnold, pa-open na yung video nyo.
Nagano yung internet ko, unstable.
Ayan, yan. Dr. Sam, yan. Dr. Angel.
Labas na muna yung mga students para magkasya tayo dun sa ano.
Yan, okay. Ganda lang
Okay.
Pwede mag-out na.
Search me. Wala eh. Wait,
mga
hindi ako
students.
naka-open.
Ate Shoni.
Yes.
Oh, yun.
Hello, Ate Shoni.
Dr. Daet, naka-close ka. Yan. Yung mga students, pwedeng labas na. Hindi tayo magkasya eh. Labas na kayo mga anak. Leave the meeting room. Students, leave the meeting room. Tatanda lang ang maiiwan. For adults only to. Students, meron pang natitira, hindi tayo kumpleto.
Hindi
Okay.
Si Ellie, nagda-drive na. Nagda-drive.
1, 2, smile everybody.
Nawala ako.
Yan.
Ay, nawala si Ate Shoni.
Oh, Ate Shoni.
Pangalan mo na lang.
Wait. Ano ba ito? Naputol yung aking
Si Lori Joy Diaz at saka si Sunny Balboa.
Wala akong video, ma'am.
Sino sila? Leave na the room. Sino si May Noel Gines?
Yung mga yan, yung kala
Yung
mo
mga
nakikinig yung
PGI.
pala nasa CR.
Tapos na mga PGI.
Ito po, ay po.
Ay, Joey.
Ayan na po.
Great lecture.
Labas na sa room mga PGI, please. Wala tayong mapaglagyan ng consultants, oh. 1, 2, smile.
Yan.
Ang dami. Sino pa yung ating consultant? Mga intern nang naririmi eh. Labas na kayo. Yung mga, sino si ACB?
Hindi ka marinig niya kasi actually wala yung mga yan. Nandun sa saan.
Kasi sila nag-o-occupy nung stage. Hindi kaya eh. O, dali, smile. Ang pogi pa naman ni Sam Uy ngayon. Mukhang congressman. 1, 2, smile.
Yeah.
Okay, good.
Okay, Angel.
Buhay pa.
Conference. Angel, salamat ha.
Wala akong maintindihan.
Pagpunta namin ng Jensen, pag wala ng pag wala ng COVID ha.
Si Angel yung last na fellow na nandyan kami. Nakita ko si Angel yung huli eh. Hindi ba, Angel? Yung last na fellow na inabutan ko eh.
Ay, bye-bye. Si Robert, wala. Si Roberto, tsaka si Robert.
Sayang eh. Yeah, Harold, thank you ha. Thank you.
Thank you.
Congratulations.
Thank you.
Congratulations.
Everyone.
Bye-bye, Arnold. Bye-bye.
Bye, sir. Thank you.
Sir, thank you.
Bye-bye, Chami.
Everyone.
Bye, sir. Salamat po sa
Bye.
ulitin po.
Oh, si ano,
Si Dr. Racel, nandyan. Dr. Maricel, oh.
Ayan nga, nasa na? Ayan na si Maricel.
Ito.
Kasi nag-o-occupy nga ng space yung mga pangalan ng intern. Pinapalabas ko, ala na kasing wala. Ayan, pati pa si si Maki. Ala. Sel, magbukas ka nga, iha. Ala. Puro kasi PG. Ayaw lumabas.
Okay na yun, ma'am. Documented naman.
Bye-bye.
Okay, thank you everyone. Thank you. Bye-bye.
Pare, salamat Arnold. Salamat.
Thank you, Lers.
Yes, Roy, thank you. Roy, nakinig talaga ako doon sa FAD, ha? Parang
galing mo kay Roy. Ganda, Roy. Ganda.
Makinabang ako sa FAD diet mo dyan, ha?
Gagawa tayo ng bago formula.
Walang i-epekto sa akin dyan. Ate Sean, kumusta ka na? Okay ka na, te? Ate Sean, okay ka na? Nakamute. Sel, thank you, Maricel. Ate Shoni, nakamute ka. Nakamute ka.
Ayan.
Yeah, kumusta ka na? Okay ka na, ate?
Coping.
Wala ka pa rin kasama?
Wala.
Di bale, tayo? Magkuan tayo, ate. Pagka, kita-kita tayo dito sa Zoom.
Okay. Sige, ma'am.
Thank you, Ate Sean.
Thank you.
Charm, Chip, thank you, ha?
Charmy, thank you so much.
Thank you. Jelly, thank you kay Dr. Daet, ha? Thank you.
Yes po. Thank you po. Thank you, ma'am.
Okay. Leda, thank you. Thank you for coming, Led. Ako si Leda. Rizal, thank you. Thank you, everybody.